And our host is always the government of Nigeria. Everything that we do is in recognition of the role that they play and the fact that we're here to support them in caring for our nation. So with that, I'd like to invite Dr. Ayaku from NTBTC to just give us a goodwill message. Dr. Ayaku, please.
Good morning, everybody. Good morning, everybody. Well, before I make my few remarks, I want to humbly recognize my senior colleagues who are in the Federal Ministry of Health, Dr. Drufa and Professor Nasidi. Dr. Drufa has been one of us right from the time he even went to become one of the MDs of the teaching hospitals, although he may not even remember because I was the younger one then. Professor Nasidi actually was the Director of Public Health, that I am now a Director and National Coordinator, National Program for the Control of Tuberculosis, Leprosy, and Borreliosis in the Federal Ministry of Health of Nigeria. Other senior colleagues, I welcome all of you to this very important occasion. We have gathered here because one of our own has come up strongly to come up with this edifice and also to show us the path, especially in this modern world where we look for evidence. How can we get evidence without research? Basically, we want the evidence for policy development and policy change. So for the national program, we are very excited to be part of this and will support it wholeheartedly. It's coming at a very right time when the trajectory of detecting missing cases in Nigeria is on the high gear. So we are very happy with this innovation, and we want to say kudos. Whatever we can do to support this drive, I make bold to say that National TB Program, National Leprosy Program, National Bully Author Control Program will wholeheartedly support this mission. Thank you very much.
Thank you very much. And we have actually experienced your support. One of the speed presentation would be one of the studies that we're doing in resistant TB that we've gotten amazing support from you and your staff. Thanks very much. The other aspect that we do at IHVN is that our research is guided by the national interest. So we do want to develop scientists of excellent cadre that can compete anywhere in the world. But we are also realistic to make sure that what we do addresses the local environment that we're in and that we address the local health challenges. You'll be hearing a lot in terms of the presentations that are going to come later. But another agency that has guided us in terms of what are the research priorities for Nigeria is the National Institute for Medical Research. Here with us today is Professor Rosemary Adu, who is representing NIMA DG, Professor Salako. So Professor Adu, a few comments from you, please.
Good morning, everyone. And
let me just declare that I'm here on my own. My Director General is on his way, and I am sure he will join us before the program is over, just to show that we are actually excited about this and what is happening here. Having Professor Alashley as even one of our scientific advisory board members in NIMA, and that we're doing something similar in research. I think it's a welcome idea, and we are happy that they're making this uh, giant strides. So I'm believing that we will provide some more evidence. We need more, not just copy and paste. We need more evidence. So the more, the merrier. So we are really excited. I'm speaking on behalf of myself. My DG will speak for himself. Thank you very much. I wish you all the best. Yeah. So science is all about accurate data, and we just got corrected there. Um, so we will get some messages from other key players in the growth of IHVN. And as you know, IHVN started as an affiliate of University of Maryland, the Institute of Human Virology. Unfortunately, the president of University of Maryland, who was planning to be here, could not come and sends his apologies. But he does have a video which we will play later on after hearing some goodwill messages from other key members in the room. And as you know, in 2010, the Institute of Human Virology that started as an affiliate of University of Maryland became its own independent institution with its own board. And representing the board to bring us goodwill messages is Professor Sago. Professor Sago, please.
Good morning, everybody. My name is Abba Sego. I stand on existing protocols because I see so many important people here. I cannot start mentioning names, but it's wonderful to have you here with us from different parts of the world, in fact. The journey of almost 20 years for IHVN had its roots in the vision of brilliant researchers and consultants of the University of Maryland, USA. In particular, Professor Bob Gallo, Nobel Prize winner, and the director of HIV in Maryland. And of course, our Professor William Blattner, who started this work in Nigeria. Being a not-for-profit organization, the Presidential USA Grant, PEPFAR, gave this institute a jump start that culminated in other grantors using IHVN to help solve some specific medical problems in this country, mainly at that time HIV/AIDS, TB, and malaria. It has been a journey of outreach to the grassroots, giving confidence to the people through various channels, and thus thousands have benefited in the incidence, and the mortality have reduced significantly as recorded yearly by the Institute. The national program in many states of the Federation could not have been successful without the leadership of IHVN and commitment of its staff, permanent and on contract. This has given IHVN commendation from state governments and the providers of grants. They recognize the varied logistics operating in Nigeria in dealing with remote communities, east, west, north, and south. And IHVN has been an example to other NGOs and even has helped them to train their staff before they started. It is noteworthy that IHVN almost always achieve 100%, sometimes over 100% of the targets set by grantors. I think they deserve a clap. Professor William Blackner is the immediate past chairman of the board. He still wakes up before the break of dawn to join quarterly meetings online. Thank you, Mrs. Blackner, for allowing him. You are greatly appreciated for your devotion and mentorship. We thank University of Maryland that through the Fothergay grants helped research fellows over many years. This concern and insight into research and its development in Nigeria by Professor Blackner has now grown into the International Research Center of Excellence, IRCE, occupying several floors of this building and being run by the energetic global researcher, Professor Abimuku Alashe. Much diversity in laboratory works and training with publications is ongoing in this institute. While we are certain that with Professor Alashley's contacts, IRCE will become recognized and patronized all over Nigeria and globally. Anyone in today's struggling Nigeria that can elevate IHVN up to this stage of development deserves accolades. Dr. Patrick Dakum rose from chief of party to be the chief executive officer of IHVN. And Dr. Charles Mensah, the chief operating officer, both seconded from the University of Maryland, worked together professionally in peace, ardently loving kindness to all, and yet with strict administrative rules with all staff. All staff were encouraged to improve their status, many bagging degrees, masters, and PhDs. Even we old-timers had to take lessons and exams in ethics. I believe we all passed. I'm sure with the agreement, the other board members and I have enjoyed working with both of you over the years. You have made us inclusive in projects, as evidenced in the IHVN campus building committee, audit committee, and others. If not for your God-fearing nature, humility, and transparency, IHVN cannot be here today, celebrating this fabulous 7-story building with a, with, with a multi-level car park. Indeed, these are just phase 1 and 2 of a 5-phase IHVN campus. We still have quite a way to go. We may even become a university at this rate. They are indeed a rare, valued breed. Professor William Blackner, our Papa, Dr. Patrick Dakum, and Dr. Charles Mensah. Please let us applaud their commitment and great success. Thank you very much.
Thank you so much. Can we give her another round of applause, please? That was very well done. One of the things that Professor Sego commented on was the fact that the sponsors that have supported some of the grants and activities of IHVN are very happy with IHVN. So let's hear from the horse's mouth. I know that Dr. Mary Boyd, the country director for CDC, representing the US government, is unavailably absent. But I do not see Mr. McPaul, but if there's any representative from CDC or USAID in the room. If not, when they come in, and the other person we're expecting is the DG for NCDC, Dr. Adetifa, they'll be able to say a few words to us. Later on, you will be able to hear some of the, as I mentioned, welcome address from really key stakeholders, the president for University of Maryland, and Dr. Robert Gallo, Bob Gallo to most of us, who is the co-discoverer of HIV. His welcoming address will come up later. But there's someone in the room that represents very early start. And as Dr. Mensah was mentioning yesterday, gave us the impetus to be able to convince additional individuals to come partner with us, not just virtually in putting grants together, but being in country and really mentoring, especially our young physicians. Dr. James Shepard is now also a farmer, and I can see the shock on his face, and we'll get a few words from Dr. Shepard. Dr. Shepard, please.
Thank you very much for this slightly unexpected invitation. So I'm afraid my words will be brief, but I'm sure that will please everybody here. But I'm looking around the room with some pride. I was the first clinical director, I suppose, of the huge network of HIV care that we rolled out in the early days, 20 years ago in Nigeria, that now is the foundation for the national treatment program for HIV and AIDS here. And I'm recognizing faces from the distant past that I used to work with to develop a quality treatment program. And I'm very proud to still see a lot of the young doctors that I work with that are not quite as old as I am, but they're getting there and they're still working, and I'm very proud to have been involved with the genesis of IHVN. So thank you, and thanks for coming today.
Thanks very much, Dr. Shepherd. I thought introducing you and coming up and giving us a few words was important, as most of us would not recognize you. A true shepherd. Now we will listen to the Goodwin address from the president of University of Maryland, Dr. Bruce Gerald.
Greetings. I am Dr. Bruce Gerald, President of the University of Maryland, Baltimore. I am proud to bring greetings to you all. It is wonderful that you are gathered here to celebrate the official ribbon cutting of the Institute of Human Virology, Nigeria. I hope to see it in person soon. I know that leaders across Nigeria are very proud to support you in this milestone achievement, and so are we here in Baltimore. I want to extend my sincere gratitude to the dedicated professionals at IHV Nigeria for their tireless efforts in the field of virology research and their commitment to combating infectious diseases. This new building is a testament to the incredible work of local researchers in Nigeria. The work being done at IHVN reflects a spirit of innovation and collaboration that defines the University of Maryland, Baltimore, and I am proud of our role in the history of IHVN. We recognize the critical role of IHVN in advancing scientific knowledge, in developing innovative treatments, and improving healthcare outcomes for their communities. IHVN will continue to make significant contributions in the field of virology and infectious diseases, and UMB is committed to our working together now and in the future. Congratulations on this milestone.
We do have a representative of the U.S. government that's going to address us via Zoom.
Please confirm you can hear me.
Yes, sir, we can hear you.
Good morning, everyone, and warm felicitations from CDC Nigeria. We thank the leadership of IHVN Nigeria for inviting us to be part of this epoch-making occasion. We're deeply proud of your achievements and are happy to be celebrating the edifice we now have gracing the skies of Abuja. Thank you for the leadership you have brought to bear that has made all of this possible. Before I give my remarks, may I apologize on behalf of the leadership of CDC. for their inability to join in person in marking this event. We're having a biennial meeting holding at the CDC Atlanta, and a significant number of our leadership are currently in that meeting. So deep apologies. With that said, I want to join in welcoming everybody who has traveled far and near to be part of this celebration, and to say that we are truly proud at CDC to have partnered with IHVN for over 20 years in the field of public health, especially through our PEPFAR program. IHVN has been one of our formidable partners, and we're deeply proud of your achievements, which is today typified by the edifice you have brought to come into fruition in Nigeria. We will continue to work with you to achieve the strategic objective for which this building was erected, and the goals you have set out for yourselves and for the country we collectively serve and the population we serve through our joint program and efforts. I want to, at this juncture, to recognize the foundation laid by Professor Blattner and team that has germinated and has beared the fruit we are all reaping out of today. Congratulations. And like Dr. Dakum would say, when I grow up, I want to be like you. But I also would want to point out the exemplary leadership displayed by Dr. Dakum, Dr. Charles, and Professor Abimiko, the triplets, as they have called themselves. We're deeply proud of you. Personally, as a Nigerian, I see your achievements as one of the testimonies we should be telling, and proudly so, of what could be possible in Nigeria and by Nigerians if we are committed to a common focus like you three are. Thank you very much for making us proud Nigerians. Thank you very much for making us a proud nation. And thank you very much for the goods this building and the effort that will be going on in it will bring to our science and technology, as well as our public health interventions in Nigeria. Thank you again for giving us the opportunity to be part of this event. And I look forward to the outcome of this seminar. Thank you, and warm regards again.
Thank you very much, Paul. Most of the programs we've done with CDC and USAID is a collaborative effort because it's a COAG, and we have really benefited from your technical and scientific input as well. So, ladies and gentlemen, I think that brings us to the end of the goodwill, and now we're going to the meat of the seminar. In the next probably about an hour and a half, we will have two speakers. So I will start with my presentation. That will be followed by Dr. Adetifa, if he makes it before then. And then we will have a video from Professor Robert Gallo, the co-discoverer of HIV. And then we will end this plenary session hearing from Professor Blattner himself. And, listen attentively for the next hour and a half, and it will really give you a very encouraging story of how very small, humble beginnings with the help of God has become an edifice that has supported his being. So I'll start with my slide, please. Great. Thanks again, Ladies and gentlemen, it's a pleasure for me to present to you today how we have harnessed scientific talent in Africa. And I believe that what we've done in Nigeria is relevant not just to Nigeria, but to the rest of Africa. So what are early efforts in Nigeria and HIV? I don't know whether you could recognize some of the individuals on this picture, but those of you who are probably same age as me would recognize the person with the red handkerchief in his pocket. This was in Baltimore. Any guesses? Any guesses? Doesn't he look out? Huh? Who? Is one of our ministers for health. Who? No. Much earlier in the early 90s. I'm blocking on his name. That's why I'm kind of playing catch up. But the name will come. He's from the southeastern part of the country. That's a hint. Okay, anyway, I'll tell you who that is. But very early on, to show the commitment of the government, the Minister of Health was visiting and meeting with Professor Gallo and discussing some of the ways that we can look into HIV. At that time, there was an opportunity to have African scientists work with laboratories that are known around the world that are working with HIV, and I got the opportunity to work in Dr. Gallo's laboratory. And at that time, one of the passion that I have, and I still have till today, was that I was interested in working with the viruses that affect my nation, Nigeria. And some of those meetings really gave us an opportunity to have donated blood tests at that time. Remember that his lab, and you will hear a lot in terms of the trajectory and what happened earlier from Professor Blattner's presentation. But just to mention that as a postdoc, I had the opportunity to be for the donated HIV test from Professor Gallo to be brought to Nigeria, and that's when we started testing for individuals. In fact, at that time we had individuals, the TV crew coming into the lab to see that we're really bleeding Nigerians, because at that time they didn't believe that the HIV was our problem. But anyway, humble beginnings, had a small lab that we were able to isolate the viruses coming from Nigeria and clearly show molecularly that it's very different from that in the West, and it's a subtype G. Later on, it turned out to be a recombinant virus, a CRF02, but at that time it was subtype G. And the rest of the Western world really had an epidemic that was due to subtype D. And these are some of the publications that was done there. But one of the things that would be mentioned in Dr. Gallo's video is also the role that this West African Wall AIDS Research Center that was developed played. It was a very modest grant of $50,000 US that allowed us to really do this test in a lab in Jos Plateau State Specialist Hospital, and to characterize the viruses coming from our country. So this just summarizes some of the reflections that I had in putting together this talk to indicate this opportunity that I had to really do a postdoc at the National Institutes of Health in Professor Gallo's lab at that time, and to be able to act as a linchpin for my country and to set up some of the scientific work that we're doing. Of course, this was in partnership with the public health, with the government, and the support that we had from Governor Darrier then. Dr. Dakin was serving under him as his commissioner for information, and Professor Nemford Gomwak, who was the commissioner for health, and Dr. Ear as well, commissioners for health. And they were the ones that supported setting up the Plateau State Human Virology Research Center in Jos Plateau that started some of this work, and that we did all of the isolation and all of the testing and characterizing the subtypes very early on. Of course came PEPFAR, which took the notch much higher, and at that time, under the leadership of Professor Blattner, we really were able to expand some of the work that we've done and move into Abuja at the minor court where we set up. 2010, IHVN became its own independent NGO, no longer an affiliate of University of Maryland, which was what happened in 2004. It had its own board and took its own decision, and look at where we are today in this great edifice. But let me just emphasize the role that the partnership, the long-term partnership, very fruitful, win-win with the University of Maryland, and we hope with other institutions in the West, has allowed us to grow and build a research infrastructure that is made of very trained, capable Nigerians, and laboratory infrastructure, data management, and excellence, and the capability of running such an operation that would pass all audits under the leadership of Dr. Mensah. So what do we have at IHVN today? The Institute of Human Virology today has a CEO, as you've heard, but in 2016, it became very obvious to us, to the leadership, that we have benefited significantly from the service program, and we have provided care for HIV-infected individuals and individuals infected with TB, and more recently with other infectious diseases, including those that are responsible for emerging and re-emerging diseases. I apologize, can you hear me over there? The speaker's gone off, but I can continue if you can hear me. Okay, all right, thank you. And so it became important for us to set up what is called a research, I was just remembering, a research infrastructure to make sure that every care that we're presented under our Center for Public Health Implementation that was heavily funded by PEPFAR was informed by good research so that we get the ability to look at the gaps. But the difference between IHVN research structure and most of the ones you find around the countries, especially at the universities, is that from the very start, we identified the areas of research we want to focus on, emphasizing on clinical trials, cohorts, studies to inform new drugs and new vaccines, implementation science to make sure that the work we do is informed by models and hypothesis that was tangible, and molecular epidemiology, because we know that as the research is going on and as infectious diseases are being researched upon, one technology, and you will hear later on in the roundtable, that has really changed the way we do things is the molecular biotechnology, in which case it really doesn't matter whether you're looking at a virus or TB or different kinds of infection. As long as you have the appropriate primer pairs, you can use the same technology of expanding the genome to understand what you have circulating. So we thought that those three core areas are really critical in terms of addressing local challenge. But the other thing we also recognized was that IHVN cannot do it by itself. We really have to partner with government research agencies and universities and academia that we're doing the same. And also not forget our international partners, especially University of Maryland. So if you look at the structure at IRCE, you will see that most of our buildings are core laboratories that allow individuals to work together in partnership. It doesn't belong to any single principal investigator, but it is available for researchers working together. So I know that there's going to be a tour of the facility, so I'm not going to spend too much time here, but just to point out what I just mentioned, that Tower A, it's made of 7 floors, but the first 5 floors are made of a biorepository at the basement that has been funded by NIH, probably the best, I can proudly say, in West Africa. It was funded by NIH for a total of 12 years, which is totally unusual. And because there is so much that has been put into that, it supports research activities across the whole of West Africa. We also have a clinical trial unit, and you will hear from Professor Blattner's presentation that one of his passions was really setting up the clinical trial unit in Baltimore that was doing HIV testing, and taught us very early on that the only way that we can be involved in experimental vaccines or drugs that are brought in, working very closely with NAFDAC, is to have a clinical trial unit that works with international partners and is really dependable. I told you about the core laboratories, clinical diagnostics. We have to continue to monitor individuals that are on this very aggressive treatment and on experimental drugs. We've got sequencing and proteomics. We continue to work in virology because a lot of our pandemics and epidemics are caused by viruses. We need to understand how the human body is reacting to them in immunology and clinical pathology, because we are also interested in cancer. And our Block B really houses our Center of Public Health Implementation. We're not having a lot of presentation on that today because IHVN is really known for the services it provides. It's on the PEPFAR and on the Global Fund for individuals that are infected with HIV and TB. But for the gala and the commissioning, you will hear more about that. So what do we have at IRCE? Well, you know that one of the differences in establishing a research institution is that it is really run by your young investigators who have their own research ideas and put in grants, competitive grants, to be able to do their research. And so these are all principal investigators that have now grown from maybe a couple of us. And there's somebody sitting in the room called Mancharurat, who is not that young anymore, but it used to be just him and I trying to put those grants together. But now this group has really expanded, and we're very, very proud of our young faculty. You will hear from them later in the day in the speed presentation of the work that they're doing, their research ideas, their funding, and they are executing it. So kudos to the young generation. One of the things that I just shared now is the fact that for us to compete with international bodies, we've really got to up our game in terms of accessing research grants. And what I'm showing on this slide is the amazing success by the young faculty that I just showed you in terms of accessing research grants, but not just any research grants, but the cream of the crop, which is the NIH research grants, and those are those in blue. And so during the years, we started in 2015, our budget for research was less than 2 million US dollars, and we've expanded our opportunity. And right now, we are at pretty much close to about $8 to $10 million per year. But cumulatively, it's a lot more than that. But what I want to show here is the fact that because we are IHVN and there are some opportunities that are not available for our partners in the West, we are able to access additional grants. So for instance, the EDCTP that funds only developing countries that are working in partnership with Europe, we're able to access those grants. And also implementation science that's coming from CDC. So we're really very proud of our faculty. This emphasizes the fact that we can compete with the rest of the world. And this really is the vision for IHVN, that we will continue to survive by competitive grants. And we look forward to getting funding also for research that eventually is going to come from our government. So what are the areas that we have worked in? Right now, we have implemented about 40 funded research activities. And I'm not going to go through all the research grants here, but there are some that you will see at the abstracts, and you can engage any of our faculty to discuss that. But these are the different areas that we're working in. We're working in clinical trials, able to run drug trials, and right now we are in the middle of putting up another huge grant to conduct HIV candidate vaccine trials as well. We've done the birth cohort since 2006. Training and implementation science, especially implementation science, is something that has developed quite rapidly in the last 2 years. Infrastructure and support is something that is absolutely critical for the research that we do because of the model that IHVN has, which is creating these core laboratories that is available for every researcher. Diagnostics, we have a roundtable with our industry partners. We realize that for discovery and moving forward, we have to work really closely with them. And we have participated in a number of development and testing of tools and software. Cancer has always been an important complication, especially now with HIV, people living for much longer with the drugs. And more recently, the global health security is something we've worked really closely with the NCDC in terms of looking at what we have. And I know that there is another SPID presentation that's going to look at the acute febrile illnesses, so that not everything we see coming through fever with fever is malaria. We're beginning to understand what are the other infectious diseases that could be responsible for that. So in the next few slides, what I like to do is just one of the things that I mentioned to you, the importance of partnership. Right now, I've talked a lot about some of the partnerships we have with the West, where now we're putting the grants, and we're telling them to come along and implement the grants with us, which is kind of exciting, because usually they would put the grants and ask us to implement it. But now the tables are turned and we are in real partnership. So that's exciting. But in the country, as I mentioned to you, that one of the things that we want to do is reach out to research institutes and facilities and continue to interact with them. This is some of the interaction we had with Bayes University, and engaging not only the VC and the Senate, but also engaging their research community, and we look forward to working with them. FMC Abuja is right next door to us, just like the Bayes University. is somewhere that we have supported in terms of PEPFAR, but there are other opportunities that are available that we are very excited to work with them on. We've been to their site and they've been here, and we will be putting some grant applications. This is part of their visit here. And again, I told you about the industry that we interact with them really closely, and Roche is one of those, Illumina as well. And these are other collaborators that have come and discussed, and I believe that this group is stationed in Germany, and we're looking to some of the collaborations we'll do with them. The West Africa Center for Excellence for Emerging Infectious Diseases, as you know, and the infectious diseases have no border. So at least for our region, this is an important collaboration that we're looking forward to, and also providing the capacity we have in the biorepository. African Academy of Science, our young investigators are very, very fully involved in that. And in fact, there is another speed run that is going to be made by a fellow of the African Academy of Science in terms of the study that he's doing with the live birth cohort in Kaduna. And we're very excited. This is NIH that have come, and part of his study is also looking at the effect of the environment. Very important at this time. LISEC, I believe, from South Africa, very important partners when we talk about establishing biosafety hoods, or even the BSL-3 for more dangerous pathogens. It's really important to have this kind of support from engineers and manufacturers of things that we do. But this is one thing that we did during PEPFAR in 2004. This was something that Professor Blattner really emphasized on. We wouldn't set up anything unless we have the engineers that ensure that it is working, and so that we don't clog our labs with equipment that's not working. So that partnership is really very precious to us. Orem Institute, I believe that they are here. We're very excited about some of the collaborations we're starting with them. They're very established and known in South Africa, and there are multi-country grants that we look forward to putting together with them. But they visited us and looked at our facility as well. And the WHO, very interested in neglected tropical diseases, which is something that is very important for us here. I'll soon finish. Again, this is an example of the NIH visit on this kid-infant study. We've worked a lot with the birth cohort in terms of understanding the transmission of HIV from mother to child, and also seeing the effects of exposure to HIV without infection to the infant. But this study has really added onto that they're looking at environmental effects of that. So with that, I would like to acknowledge really the many partners and the funders that we've worked with. Slim Karim and his wife have really been foundational in supporting us in a lot of work that we do in clinical trials. And colleagues from University of Maryland, certainly you will hear from Bill Blattner. Man Chararat has taken the torch now and is really working and expanding this collaboration. Bob Gallo, unfortunately, he's not here, but he will be sharing a video. Obviously, all of the staff at IHVN, you've just been amazing to work with. And our board have been completely supportive and really have rolled up their sleeves and work with us in everything that we do. So thank you for your attention, and I'll take one or two questions, and then we'll go to the next presenter. Oh, that's a hand there.
Yeah, good morning, everyone. My name is Abraham Alabi. I'm really happy. I'm proud to be here to listen to you, Professor Lashile. And I really know a lot of the work you did. And at the beginning, we interacted.
Yes.
It's good really to be saying this, coming to really very great fruition. So well done.
Thank you.
A round of applause for her, please, and the team. Yes, I just wanted to ask whether you have any interaction also with the European Commission. I know that you are involved in all of this, and I saw funders like EDCTP, NIH, but specifically I just wanted to know what is your interaction with the European Commission. Thank you. Yes, thank you.
Thank you. My comment is going to be very brief because, as you know, the European Union is now taking over a lot of the work that EDCTP does in terms of the Horizon 2020 program, and then now is 2022. So we continue to look for opportunities through that. We certainly want to interact with you. This is an amazing Nigerian in the MRC in the Gambia, and has done excellent work there in terms of molecular work and sequencing. So we want to continue to interact with you, especially through the MRC that comes through Wellcome Trust. So I'm glad you were able to make it. Welcome. One more question. Can we have Dr. Adeti first? So while I was rounding up, we had the honor of having the Director General for NCDC walk into the room. Dr. Adeti, you're welcome. I know you've been traveling and you literally came off a flight, I believe, I don't know, from Geneva or something, but we had a meeting with the minister and he was telling us how you have to travel around the place. So we're really glad that you're able to come, and you will address us for the next set of lectures. I believe we got your slides, and we are ready to hear from you. That's that one. You're welcome. Great.
Let's hope I survive the technology. It's a brand new building and facilities as well. So, good morning to the leadership and the team here at IHVN. And permit me to, as we government people say, to stand on already established protocol and just dive into my talk. It's a pleasure to be here and privileged to have received an invitation to this August event we're holding in June. The work that IHVN does speaks for itself. It's a long record, good track record of work in the country, and we are happy as one of their partners to see them achieve this additional milestone. I've been asked to speak about epidemic or emergency epidemic response and speak specifically about lessons from COVID. Let me warn you that I'll be talking about more than COVID, because I think that COVID was important, but in the national and perhaps continental or even global health security agenda, there perhaps has been a bit too much COVIDization of everything. So I think we have an infectious disease problem, and it's not just us, but we have an infectious disease problem. And I'm, of course, focusing on infectious diseases because my agency, the Nigeria Center for Disease Control and Prevention, has a remit for communicable diseases. You know, so if you look at the headlines, cholera, leptospirosis, fungus, meningitis, Crimean Congo, and that's just a few. But then if you look at, everybody's familiar with the IRCE PROMED notification, and this is a map by infectious diseases. I think this is probably from last year, but you can see the continents, and Nigeria, unfortunately, is responsible for that large cholera caseload at the time. But humanity, or the global, the global humanity across the globe is besieged by microorganisms and by infectious diseases. And as I tell people, it's really a matter of survival for the pathogens. There's nothing personal. Just as we are hustling for survival and hoping that you know, we close the track or close the gap between us and the Aliko Dangotes and Bill Gates of the world, the pathogens are doing their best to meet their own basic needs, which really is just to survive and to have babies. That's all. Okay, but in the context of doing that, they have to do that in the same environment that we cohabit with them, and often that means that we have clashes or we have interactions. So, you know, if we sort of talk about with increased globalization, you know, and everything that is going on, there is a far wide-reaching impact of infectious diseases. Nigeria, if you take Nigeria as an example, most airports here have a flight that is just 6 hours away from most European capitals. And well, our colleagues from the US across the pond from the UK are slightly further away, but I mean, usually we'll be with you in another 8 hours after a brief transit in any of the European airports. And the same applies the other way. So I'm not trying to reinforce the diseases come from here, but we're Nigerian. I'm just talking about the direction. So we had the pandemic. Of course, this number continues to change, but we've had almost 800 million cases and almost 7 million people die. And sometimes when you throw around numbers, people typically, the numbers go off the top of your head. But I like to look at this in the context of populations. So if you take countries like the Gambia in West Africa, Gambia probably has about 3 million people now. So that's almost more than 2 times the population of one country. If you add Gambia, Cape Verde, Sao Tome and Principe, and some of the other small countries, you basically wiped out COVID basically wiped out entire populations of some countries. And if you come to Nigeria, this will be 2 times the population, or almost 1.5 times the population of my own state. So imagine if everybody in Ekiti disappears in 2 years of a disease outbreak. So large number of people who died, and that's direct deaths. We're not talking about indirect consequences, people who couldn't have essential or emergency surgery because of lockdowns, people who couldn't get to their medications, and so on. Well, we've got ongoing outbreaks because of organization. So if we sit down and try and properly quantify the impact of this pandemic and perhaps other outbreaks, there are a lot more sort of the wide-reaching disruptions to business, education, travel, job security, and all of the stuff that immediately jumps out at us. Obviously, the economical consequence cannot be overemphasized in terms of jobs that were lost, children that were impacted. I was in Kenya for the start of the COVID pandemic, and I was acutely aware of the privilege that I had and the privilege my children had, because they spent all the time at home online schooling, did not miss a single term. Children in public schools were at home for 1 year, basically, and this is the same story in many countries. So let's come to West Africa. We had Ebola, largest outbreak ever in the sub-region, 2 billion losses in GDP, and of course, we had an example of a regional outbreak, even if not continental or worldwide, affecting essential services, disruptions to HIV, TB, malaria care. But I think the thing that has happened is perhaps we didn't learn that lesson. The world does not seem to be willing to learn lessons from all of the disease outbreaks that have gone before. We are all very keen to say bye-bye to COVID and completely forget the lessons and keep up the investments that are required to make sure that when the next outbreak strikes, and it will certainly, the next outbreaks will happen, that we are better prepared. We do not have the same, we are in a better position to mitigate all of these impacts. We've had Lassa fever outbreaks, and it seems like every year, coinciding with since I arrived, case numbers are going up. I'm not suggesting there's any causation there, but I just find it very upsetting that despite everything that we try to do, Lassa fever arrives on schedule, spends the length of time it wants to spend, and then says bye-bye, see you later. And there's very little we can do about it other than, well, we have been making some progress in terms of reducing the case fatality. But there have been gaps, lack of investment in diagnostics, in development of vaccines, in development of therapeutics. And perhaps that is the case because it's not the most easily transmissible condition in terms of being for a sick person to get on a plane and fly somewhere. So COVID, we had, 266,000 cases, little more than 3,100 deaths. And these are direct deaths. I, for one, know people who, because of lockdowns, died at home because they couldn't get out to emergency care. So if we start to add all them up and all of the undiagnosed elderly deaths, people assume it's normal for old people to cough, and if they are coughing and they are fine and they fall ill, old age is a cause of death, which is acceptable and often attracts very little inquiry, which I think is wrong. But 20% of our workforce lost their jobs, and of course we went into recession, and everybody knows what the data looks like. So what can we learn, or what did we learn? In terms of the response, the country did quite well in ramping up surveillance. So starting from the Ebola outbreak, followed by monkeypox outbreak, the country had started to deploy a digital surveillance system to replace the paper-based one. So with each outbreak, large outbreak that came, this was ramped up. And in the context of COVID and the investments that it attracted, digital surveillance became nationwide and replaced paper. We moved from not being able to diagnose COVID in more than 2 laboratories to having perhaps what may be considered more laboratories than we need for molecular diagnosis across the country. We were forced to have a national stockpile, which then enabled us to respond with medical and non-medical countermeasures to support response in states. Public health emergency operations centers were scaled up worldwide. But I think just like everyone in the world found out, it wasn't a journey to be traveled alone. Partnerships were essential. The private sector contributed immensely to the response. Actually, private sector filled the gap while government was still trying to mobilize resources in terms of consumables, sanitizers, equipment, and all of the like. So the strategic partnerships that were driven by the response facilitated the response that we had in all of these areas that are listed here, and we continue to maintain, and indeed we want to strengthen and expand those partnerships. We saw the demonstration of political will at the highest level. In fact, Nigeria is praised for the way it deployed exemplar political will at the highest level in terms of responding to the pandemic. The president, by executive order, constituted a presidential task force on COVID, which later became a presidential steering committee on COVID. This was multi-sectoral, so you had all the MDAs, where we call ministries and departments and agencies across board, aviation, internal affairs, disaster management, all sitting down in an incident management center, or EOC, to look at the response. And this was chaired by the Secretary to the Government of the Federation, which I think made for very easy multi-sectoral coordination of the COVID pandemic response. And I say that because having been part of COVID response in another African country that did not have that arrangement, this certainly worked a lot better. Everybody, we ensured everybody was on the same page, and then went away with the action points that they had to implement. And this was established just about 2 weeks after the country's index case was identified. And this was the outline. So you had the presidential task force with 12 members, so ministers of 7 agencies, 7 ministries, and then all of these others listed. And of course, the Ministry of Health and all of its relevant agencies, the Primary Health Care Development Agency, who's responsible for vaccination, all of the research institutes, and of course, the NCDC as the agency or the EOC. Again, COVID was, another lesson was the benefit of handling data differently. So there were those press conferences that held where case numbers were announced, citizens were briefed on what was being happening, or interventions that were ongoing by people in the highest levels of government, so much so that this became something people looked forward to. And when it didn't hold as scheduled, there was immediate outrage. You think it was something that was happening. And this is, if it had just been rescheduled to a slightly different time or pushed back or forward by 1 day. So there were still skeptics, but nobody could argue that data not being shared or reported on a daily basis. And of course, you can only report data in live or in real time if you have a real-time surveillance system, which again was another lesson learned. And in terms of real-time surveillance, I'm talking about indicator or case-based surveillance, and how you, of course, need to evolve from paper to a digital tool that allows you for real-time inquiry. And this just tells the story of the way digital surveillance evolved. As I said, started in high-risk states after the Ebola outbreak, was ramped up when monkeypox reappeared in 2017. And then with COVID, the loop was finally closed to cover the entire country. The NCDC beyond COVID is really, the story cannot be told without talking about strategic partnerships, domestic and continental and international. From a project in the Federal Ministry of Health to an agency with its own enabling law in 2018, the NCDC has benefited from immense support and collaboration, including collaboration with, suddenly everything's gone quiet. So, all right. Including collaborations with IHVN, the likes of IHVN, where we are today, and other similar institutions in the country. And the strategic support we've received has contributed significantly to building capacity of the institution, strengthening our role as the international health regulations focal point or focal entity for the country, and of course, the whole area of emergency preparedness and response. So this just tries to, and my worry with things like this is that you often, despite your best intentions, will leave somebody out. But please, if you represent an institution that, let me just move that away quickly. If you represent an institution that, for some reason, despite our best efforts, you don't have your logo here, please, it does not reflect the value that we place on you. But this is just to highlight, give a sense of, the spectrum of partnerships that are required, either in response to outbreaks or even a pandemic. And to take note that everybody thinks outbreak response or pandemic response is a health issue. It's not just a health issue. It's an all of government and all of population issue. So your technology platforms need people like Microsoft, people like, Xerox and co. You need data, you need telecommunications, you need, so all of these partners and more, you need across sectors to manage, indeed to prepare and to respond to disease outbreaks. So we are grateful. We use this opportunity to again thank all supporting partners, including our colleagues in other government agencies, or corporate organizations, associations, even individuals and civil society. So I think coming to the end now, just to summarize, key lessons: political will and context-specific strategies are important. One of the things that I think, for want of a better description, really pissed me off about the COVID response on the continent is the, poor, relatively, poor interest in contextualizing our response. Everybody tried to copy and paste to a large extent, and that varied across countries. But we need to be more bold and use our own data to drive and contextualize response, even as we uphold our end in terms of contributing to global health security. Reliable data is certainly critical for informed decisions, so you can track occupancy of isolation and treatment centers, what's going on with oxygen, what's going on with caseloads, what's going on with transmission in context of serosurveys and the like. And strategic collaborations and partnerships are essential. I don't think we can say too much about that. I talked about not learning lessons, and whether it's nationally or across the globe. And I think it's important to focus in-house on our own businesses, that we need to learn lessons. If there's any lesson we need to learn from the world now is, sadly, when the chips are down, you're on your own. That is the lesson from COVID. When the chips are down, when there's a really big, overwhelming problem that affects millions or thousands of population at any one time, I'm sorry, you are on your own. And it's, if I'm overwhelmed in my household by challenges, whether financial or otherwise, I've got very little latitude to take on anybody's problem. And we saw this. And I think, in the context of partnership and perhaps receiving help from others, you are being helped, you do need to lift the heavier end of the load. So I'm all for governments and national entities taking, first of all, responsibility for their own destinies, but recognizing that, yes, you don't have all of the capacity and resources you need and may also benefit for help. So the 1918-1919 influenza pandemic mirrored the COVID-19 pandemic. The talk was about another flu pandemic after 100 years. We got a coronavirus pandemic, which means that that flu pandemic is probably still going to come. We see crazy bird flu or animal flu strains arising every day. Obviously, they do not, and thankfully so, do not seem to have acquired capacity for wide human-to-human transmission. But it looks like it's only a matter of time that that would happen. So we need to make sure that we are prepared to mitigate all of the consequences of any future pandemic, or even if it's a countrywide or regional or continental outbreak. It is in peacetime that we need to race to develop diagnostics, therapeutics, and vaccines. And it is in peacetime that we need to work to contribute to resilience of our health systems. Everybody received were in shock at the onset of the pandemic, but we can't see how countries with resilience in their health system pivoted differently, and that's something to aspire to. So what will it take to be better prepared? I've already talked about health system strengthening, work on rapid diagnostics, alignment with the 100 days, the vaccine development agenda, and similar things. But as I alluded to earlier, country-led approaches for health promotion, disease prevention, emergency response, and indeed communication. Later this week, we are going to be talking about the work that needs to be done in peace. Okay, there's been historical quite a bit of good communication around vaccination, and so some of which we may have lost, given what we are seeing with vaccination, with the problems with vaccine preventable diseases. But we need to go back to speaking more about health promotion and engagement with communities when there is no outbreak. Apart from the fact that it allows you to also establish the relationships and of trust that you need when an outbreak comes. It's difficult to establish a relationship of trust with communities that you previously didn't engage with and who are seeing you for the first time when there's an outbreak. Of course, they will be suspicious and all of that. There's a need to, of course, continue the investment in strengthening laboratory diagnostic capacity and surveillance. Please, for those who may be connected or have influence, surveillance cannot be separated from clinical care, because it now seems like we are taking that as something separate. If you cannot make diagnosis and properly investigate patients who present at every level of healthcare, then you are not likely to be able to detect outbreaks quickly when they occur. And this needs to happen in the healthcare setting. Of course, we need to better position ourselves to absorb and to use the data that we are generating. So thank you for tolerating the ramble, but I hopefully would have left you with at least one message or two to take forward. Thank you very much. Okay, I've been told I can take a question and a half if there are any. I just rounded it down to reduce the length of time I spend on the podium. I think I see a hand here. Yes, please. Fortunately, I can see who it is.
Thank you. I'm Emmanuel Ekanem. I'm a pediatrician, Emmanuel Ekanem. I must thank your agency for the response to the COVID problem in Nigeria. The problem became a lot less than we anticipated. I must thank you and your agency for that. But listening to you, I would like to ask, how did you and how would you address in future the problem of misinformation? That was a major problem during the outbreak here in Nigeria. All sort of messages in social media, people refusing vaccine. One particular one was very popular. Some fellow somewhere in the US stood and said, I am so PhD, Oxford, and don't take the vaccine. And it happened to be that he was living on Oxford Street, somewhere in the US, and had an online PhD. And people just blatantly refused to take the vaccine because of this misinformation. I didn't hear you handle how you address that and how you will be able to address that if similar things should happen. Thank you.
Thank you very much. As I said, about communication, whether it's risk communication, whether it's community engagement, that needs to be done now. You need to establish relationships with the community and talk, about promoting health. We shouldn't always have to, my agency, everybody calls my agency's name in short, the Nigeria Center for Disease Control. We're actually a Center for Disease Control and Prevention, and I have to remind us that so the idea is not to sit around waiting for things to happen, then go and control them. You're meant to prevent, detect, and then respond to public health threats as they occur of a communicable disease nature to mitigate their impact. And one of our strategies, as I sort of said earlier now, is to work with partners, including the Health Promotion Division or Department in the ministry, and at subnational level especially, to communicate about diseases in peacetime. If the first time you see people talking about meningitis is when you have a meningitis outbreak, there is no relationship of trust. You do not, yes, it makes sense to you, you're talking about a disease, it's killing people, but from the perspective of the community, they don't know you. They never saw you before. Where were you when they had other problems? Where were you, for immunization, for water and sanitation and hygiene and all of that? And that's the work that we all need to do now, collectively, health promotion in general, learning and developing context-relevant materials for discussing disease. As I said, in my language, everything that causes a disease is an ant. It's kokoro. Okay, kokoro that causes this, and then ants are typically seen, so you have to say kokoro that you cannot see with your naked eye, and I don't know what the equivalent is in other languages, but we now need all of the, anthropologists, scientists, all the science writers, communicate. We now need to develop proper communication around infectious diseases, and indeed, not to say that NCDs are not important, but infectious diseases now, because part of what happens during outbreaks is that we start getting requests from states for IEC materials, but you now have an outbreak, okay? It's a bit difficult to, you want to respond to the outbreak, you want to look after cases and manage mortality. Sometimes that takes away from any effort to work on IEC material. So long way of answering your question is that's an important strategy for us along with everybody else, and we are working very hard to do just that. And I'm sure, I assure you it's the same, it's the case with a lot of the other diseases. I know, for example, this year, even the colleagues in the TB program have been doing a lot of work about trying, to communicate the need for TB diagnosis or TB investigation if you have been coughing for more than 2 weeks. But I used to work on TB a long time ago when I was in the GAM. It's the same story. You just cannot stop communicating, because otherwise people, in that gap, something else is provided to fill. So that's the risk. So half question or another one if there's any. Yes, ma'am.
Long COVID, and you sounded as COVID is over. So what are we doing? What are we doing around? What are we learning around long COVID? And do we have data as of today, or Nigerians are not suffering from it? Thank you.
Yeah, by no means did I suggest COVID is over. I'm certainly not saying that. What has happened is, yes, the acute phase of the response is over. Well, personally, I can't tell you COVID is over. I still had the positive COVID test in April, thankfully mild symptoms, but just in April. So you are not at any risk now. So So the area of long COVID is not very well investigated here. And the agency has had conversations with colleagues, the infectious disease professionals, to sort of see if work can be done on that area. And some are looking at it, but the short answer is there's not a lot of data. Long COVID now is sort of in the realm, if you take data from elsewhere, of sort of chronic ill health, which sort of takes it out of my purview, okay? Especially now that the face of the pandemic response that we're in is integrating COVID into every other day care. So this is in the realm of case management, of clinical care. And I know that there are colleagues in a few hospitals, members of the Nigerian Infectious Disease Society that have an interest in COVID, but there's not a lot of data. It's nice. So zero data does not suggest that it doesn't exist. We need to look at it, but it might also be that given the variation in the presentation of COVID in our part of the world, we might not have as much of long COVID as reported elsewhere. But that is just a hypothesis. We need to look. I'm all for searching for something before you write it off. Okay? All right, thank you.
Thank you, Dr. Adetifa. That was very enlightening. So thank you for your patience. We started a little late, so the program is a little behind. We do have two very interesting sessions to come before we take a break. One is going to be the video from Bob Gallo, and then the next is going to be our keynote speaker, Professor Blattner. But before we play the video, Professor Salako walked in while you were presenting. He heard most of your presentation. He didn't miss it. And earlier on, I actually did call on Professor Audu and said she was representing you, but she quickly corrected me that you were on your way. So we're glad you could make it, and we will take your goodwill message now and right after he's done, please play the video. Thank you. You're welcome, sir.
Thank you very much, Professor Abimeko. Good morning, distinguished ladies and gentlemen. I would like to first apologize. I had to leave Ibadan this morning, and there was only 2 flights. The earliest flight was 8:30. So as soon as the plane touched down, I got the driver who came to pick me and found my way here. So please take that apology. Now, my message will be to say that since, I don't know who I met first, whether it's Alexley or IHVN. I think I met, but I would assume that I met her first, and then I got in contact with IHVN. And since then, it's been a very fruitful relationship between her and myself, and then between IHVN and my institute, which is the Nigerian Institute of Medical Research. And she's been doing a lot of pro bono work for us as members of our research advisory committee. Even in the midst of trying to organize this meeting, I still asked her to join a meeting only a few days ago. She's really a woman of energy. IHVN has been supporting a TB program in my institution. And the last 1 year, we've also been involved in the research on TB, and both of them, I believe, are going pari passu. and we are getting the support that we needed, not just about equipment, but also about training. Professor Audu, who spoke here before me, is actually the head of the microbiology, so he knows a lot of the other gamut of help that they were getting from the institution. So for us in Nigerian Institute of Medical Research, we cannot but support any effort that the IHVN is making. But I must make a confession. About a year and a half ago, we were having a meeting at the Ministry of Health, and IHVN was listed as a government agency. Maybe because of I was very jealous. I said, IHVN belongs to, I believe, University of Maryland, and that it's not a government agency. I was surprised that many of them didn't know. That's why they had to put, it shows how frequent or the enormous activities that IHVN has been doing with the Federal Ministry of Health, such that they don't even know. So sorry I had to get them to remove you. But I know that you are capable of doing it alone, of course, with your partners. So I see this launch today as another step in your contribution to science, not just in Nigeria, all over the world. And I believe it's going to be a game changer for research in Nigeria, especially that you have, I don't know whether all the support that you need because of where you're coming from. And for us as government agencies and researchers, we are still battling to get enough fund, to get enough opportunity for training, to get all of those things, which I believe you are capable of providing for us through partnership. So for me, this is something that should be embraced in Nigeria. And I recommend that generally to all researchers. So distinguished ladies and gentlemen, I thank you very much for this opportunity.
Hello and good morning or good afternoon. I'm not sure what time it is in Nigeria right now. I'm Bob Gallo, and I'm recording this because I am not with you, obviously, and I wish I were with you. I want to start by saying congratulations on the new development, the new Institute of Human Virology in Nigeria. Thank you for keeping the name and the memory of us. I want to personally thank Charles Menso and Patrick Dakum and Lashley Abimiku for their great work over the years. I think back, and it seems to me that you started with us as birds that were learning to fly, but really actually could fly. But maybe you didn't reach the heights you wanted to reach. And then over a period of time, you've now really spread your wings and you're flying high enough so that you may grow distant from us, but I hope not so distant that you forget about the IHV Baltimore, or that you'll forget to keep me sometimes in your thoughts as I move to a different position. First, I would like to give some background of how I see the developments in our relationships with African nations, and in particular, Nigeria. For me, it starts at the beginning of a major US effort to be involved with Africa. One of the spin-offs positive of a silver lining of the black cloud of AIDS. It was when we made the French-American cooperative agreement, so-called Franco-American agreement, to share royalties from the HIV blood test, and decided to put a significant component in that into the training of African clinician scientists throughout Africa. This was while I was at NIH and was really right at the early part of the pandemic. And this worked. The money was put over to the Fogarty International Center, but came out of our patents for the blood test. And people were funded for the first time in a very major way in numbers for training in HIV clinically and HIV research specifically. But the part that really took off and really got us at IHV very engaged with Africa happened really about the same time, but quite independently. Off the western coast of the Italian island, Sicily, right above the waters where the general Pyrrhus had a victory over the Romans for a while. Why we call it a Pyrrhic victory, because when you beat the Romans in those days, they never forgot, and they come back again and again. Finally, of course, they defeated the Carthaginians. But right above those waters on the western coast, an area dominated by Phoenicians, but then Rome taking over little by little, while Greeks were elsewhere throughout the island. In a mesa, high above, was a tremendously beautiful town, medieval in its history of the current structures. That is, it went back to about 1,000 years ago. But in reality, it dates back many thousands of years. It goes back to a people that predate the Romans, predate the Greeks, predate the Phoenicians, and they were called the Elime, or Lima, something like that. And they built their town on this mesa for a center of fertility rites, whatever that means. But in time, and into our century, not this century, but into the 1900s. Around 1930 or so, there came a school called the Moriano School that was started by the great theoretical physicist Enrico Fermi. Moriano was a young man that Fermi thought was the smartest theoretical physicist he ever met for a youth. And he disappeared one day off his nice day where he was sailing with his son off the coast of Genoa. It is thought that he was picked up by it was toward the end of World War II. We don't know who picked him up, but he's never been seen again. Anyway, in that school, physicists gathered, famous physicists, including Albert Einstein, including the whatever you want to think about it, the father of the hydrogen bomb, Edward Teller. In the course of time, the head person of that school became a man named Antonio Zucchitti, an Italian physicist, and he decided to have things that were, the Italian government gave him a lot of money to fund things, I should say, rather than he decided, to fund things that were related to world terrible problems. And he focused on earthquakes, he focused on volcanoes, and then came his first entry into biology, malaria, even though he was a physicist. One day I got a call from him. He had millions of dollars to give out. And he asked me while I was at NIH if I could help Africa in HIV and AIDS. I don't even remember the exact year, likely to be late 80s, maybe the beginning of the 90s. And what I did with that money, after getting approval from NIH to be able to handle it, actually I got a treasurer in France to handle it, was to give it to European scientists, European clinicians, scientists, to train people in Africa. They had already these close contacts with African nations. We did not. And America was not so fully involved in Africa then, as I said. AIDS changed that. Then one day I received an application from a young lady to work with me. Her name was Olashli Abimeku from Nigeria. And this begins a separate story of what led to the United States help to Africa. While she was working with me in the laboratory, the PEPFAR programs were created. the President's Emergency Program for AIDS Relief, which really was a tremendous boost to U.S. being involved in helping with AIDS in Africa. And Lashley and I working together at NIH, it was clear that she was expressing more interest in the public health and epidemiology part of this problem. I had close collaborations with my wonderful nearby colleague, Dr. William Blattner, epidemiologist, public health notions, an invaluable collaborator for my colleagues and myself, and we became good friends in that period of time. And so I asked Lashley to work with Bill, particularly when in 1995-96, we moved to Baltimore and formed the Institute of Human Virology. Ashley Abimaku did something different. We, of course, had postdoctorals coming from different parts of the world to NIH for many years. We had received many in our laboratory. And of course, they helped catalyze good relations. Of course, they catalyzed benefits to our laboratories as well as to their home country. But they were gone in a couple of years and gone forever, and the contacts were usually almost always broken. What Lashley did was not unique, but very rare. She went back and forth over years and years. And what did this do? It made us gain more and more. And it made, I believe, help to her Nigerian colleagues more and more. It is out of this that this whole phenomenon was baked. But it was baked with the heavy sugar of the PEPFAR program, without which none of this could have really fully developed. And so we owe thanks to the originators of the PEPFAR program from the United States as well. So Lashley carried out really great work. And all of you, people I've mentioned and the many that I haven't mentioned in Nigeria, carried out great work. And from this collaboration and the PEPFAR work, you have become really independent. Independent, I hope, collaborators that still will draw on the connection with us. We have great affection for you, and I hope you have affection for us, and that will continue as long as, well into the future, if possible. So congratulations on the new building. Congratulations on your work. And I thank you personally for naming it the Institute of Human Virology, Nigeria. I now want to turn my attention to speaking a bit about HIV. I was asked to say words about the two subjects. I've completed one. Now I'd like to tell you how I see the future of HIV. I believe we've overstressed big, large, organized, cooperative programs for vaccines. An enormous amount of funds have been spent for that, and there has been, as you all know, no real success. And it seems to be going on and on and on. There needs to be what we all believe in: cooperation, collaboration in global health problems. But it is when they reach a certain maturation. Prior to that, to do innovation, we also need the relatively lonely investigators, innovators, doing creative research. Let's not forget them. This is necessary. And to fund those big programs, really billions of dollars now, that have been unsuccessful in doing essentially the same thing over and over again, we have not fostered the development of careers of people creative ideas, or fostered enough innovation, or not so young, that might have moved the clock forward to a closer time of success. I believe this has to change. An HIV preventive vaccine is not on the immediate horizon, but I can honestly tell you I see hope coming from certain directions, but they are different than the current directions. Again, I will speak. We need a bit more of loosening of the reins of control from central government on this, and freeing up independent ideas of independent investigators to reach a point where we can become super collaborative with clinical trials in a more productive manner. What else do I think about in terms of the close future of HIV research? I think we will reach a functional cure. I think that means we won't need therapy anymore, or at least it'll be rare to need it or unusual to need it. I believe, however, that it won't be from the way things have developed so far. We have had great success in treatment of a viral systemic serious disease, HIV/AIDS, first time in the history of medicine that a serious systemic viral disease has been treated and treated successfully with objective data, with a rise in immune response and a decline in virus titer, proven. Back even as early as 1986 with AZT. So now, with combination therapy and many drug companies, we've reached the now epitome, I think, probably as far as we can go by targeting steps in the HIV replication cycle. We gain the ability to do this out of the molecular biology, molecular virology of understanding each step of virus replication of HIV. And in so doing, we've had these drugs targeting these steps, but I think we now have run out of steps. And what will happen new will be the long-lasting drugs and maybe better delivery. I don't think some of the other approaches, however, will work that are ongoing, and I'm not going to get into that because it's my personal opinion, maybe my bias, and I don't want to speak negative about any investigators' trials. So where will the next advances come from in my judgment? I think out of detailed study of pathogenesis, namely the mechanisms, cellular and molecular, of how HIV causes AIDS. I believe there'll be great progress in that line in the coming year. I am feeling extremely happy that I'm part of a collaboration with French colleagues, my long-term on and off collaborator, Daniel Zaguri, and other colleagues in the United States and in Italy and in Belgium. And that we have a chance out of these pathogenesis studies, I think, to really reach a functional cure. I hope this happens in the coming 2 years' time. I say that with hope, but with optimism as well. I will try to focus on that topic, as well as some aspects of new approaches to the study of the origins of some human cancers. Let me close by saying again, I wish you the heights of success, and I know you're climbing towards them. And my hope, my wish is that we will stay connected with IHV generally, with the university generally, and even with me personally. Thank you very much for your time.
Thank you very much, Professor Robert Gallo, the co-discoverer of HIV and a very close friend of IHV. We have all been well mentored. And our next talk before the break is by another very distinguished mentor that we've had throughout the years, a visionary, and who will give us a key address in terms of the history and some of the personal reflections in terms of our relationship with IHVN. So please help me welcome Professor William Blattner.
Well, today I'd like to share a little bit about my own story and tie it in with a little bit of science. And this talk is really oriented towards the young people here, so that they can get a little bit of a perspective on how life unfolds and in ways that we can never predict, and how if we keep our eyes and ears open and pray from time to time that things are going to go well in our careers. So I'm in my 80th year, and so I can look back on some of the events in my life and my career that helped to inform this. We'll start back in the 1950s with the discovery of the first mammalian retrovirus that caused leukemia, and it was work led by Ludwig Gross, who's shown here, and this is the virus. And here I am at that same time thinking all about these viruses out in the wheat fields of Kansas. And so fast forward a few years, I've gone to medical school and really not sure what I'm going to do with my life, but we're in the middle of this war in Vietnam and thinking about the opportunities of the Public Health Service, which is the uniformed services in the United States, to serve the public health of the people. And so in 1972, during my medical training, postgraduate training, I went down to Rockville, Maryland, and had an interview for a job at the Federal Drug Administration in the Public Health Service, but I wasn't selected. Later that year, in the middle of my rotation in intensive care, I could hardly think at that point, because we were working 24 hours a day, I got a call from the National Cancer Institute inviting me to become a clinical associate in the epidemiology branch. I knew nothing about epidemiology. It wasn't taught very much in medical school. I said, well, this is a great opportunity to learn something new. So my plan was to do 2 years in public health service, but God had a different plan. 22 years later, I retired to help co-found the Institute of Human Virology as a member of the so-called Dream Team. So my scientific formation was important because I really had no scientific background at that time. John Mulvihill, who's a friend today, was the person who pulled my resume off the reject pile and invited me down and has mentored me ever since. Bob Hoover, a recent MD, PhD, taught me the fundamentals of epidemiology. And Joe Framini, my boss, taught me the importance of supporting young investigators. I was someone who had no real background to do science, but he encouraged me, gave me opportunities, and he funded me. And I think that's an important lesson here in Nigeria as well, that sometimes we can get caught up in the seniority trap, and it's very important to provide opportunity for young investigators to have these experiences, make some mistakes, but also have some opportunities to be successful. Bob Miller was one of my other important mentors, and what he taught me was exemplified in this cartoon from the New Yorker, which was science is a herd type of activity. You'll see that there are big trends that go, as Bob Gallo was talking about. Everybody's going in one direction. There's an orthodoxy. And the key to successful science is to be that seagull looking the other direction and looking at the opportunities that open up on the other side, and to follow those instincts and to create a new path. And my career has been very much involved in looking the other way and seeing opportunities before they became fashionable, and being ahead of the curve. So my first research was involved in cancer research, studying familial cancer, and this was my first author paper, which came, as you can see, 3 years after I arrived. So it took a long time to incubate some scientific capacity, and so you have to be patient with these young investigators. And what we found was there was an inherited defect in a particular subset of cells in this family that resulted in 4 or 5 siblings having chronic lymphocytic leukemia. It went on towards the end of this phase of my career, which was integrating laboratory science into clinical science, to be involved in discovering a really important cancer gene in a syndrome called Lee-Fraumeni syndrome. It's a cancer syndrome which is exemplified by multiple different types of cancer. And when a lot of the clinical work I did basically said, there's a fundamental gene because you have cancers of both the epithelial and the mesenchymal regions. You had leukemias, you had breast cancer, you had all kinds of cancer. And working with Esther Chang and her group at Georgetown, we discovered a mutation in the P53 gene, which is a fundamental gene in cancer and is a target for treatment today. So getting on to the personal side of things, here are the two most important days of my life. So one day, shortly after I got to Bethesda, Maryland, I was given the number of a young lady, and I gave her a call, and she was working 3 jobs and going to school, but she happened to be off that afternoon and needed a sailing partner. So I volunteered, not knowing much about sailing, but pretending I did. And so this very attractive young woman, I was smitten with her, and not too long after we got married, about a year later. It's very important to have a good partner because she's made many sacrifices over the years. So my first encounter with retrovirology also had an important lesson. Bob Gallo and his team were one of the leading groups looking for this virus in humans that Ludwig Gross had discovered back in the early 50s. And so you can see that science incubates over time. It doesn't happen overnight. And he had identified a virus called a type C, which is now called retrovirus, in the cells from a patient from Kansas who was being treated at MD Anderson in Houston with myeloid leukemia. And so Joe Fraumeni referred me over to his Italian buddy Gallo because he needed an epidemiologist. And so this led to my second honeymoon. So Diane and I got on this plane and flew cross country to a place called Salina, Kansas, which is out in the middle of the wheat fields. And we drew blood and so on and so forth. Brought him back. I think we had him in our refrigerator at home maybe, but anyway, we took him to the lab. And I must say, when Diane saw the plane, fortunately there was a priest on the plane and she sat next to him. So it's also important to pick your seat partners. And so that didn't pan out. But the important aspect of that was that I didn't go in and say, Bob Gallo, I want to be first author on this paper. I didn't get a paper out of it, but I got a friendship out of it. And I got the trust of him because a lot of people come in and they try and leverage their way in and stiff arm and whatever, bend arms, whatever you call it. And so he realized that I wasn't someone who was going to just come in and try and take advantage of him, but rather I was someone that was willing to be a team player, and it built that first trust. So that when he did discover the first human retrovirus, which is HTLV, which culminated the multi-decades long search for this mammalian leukemia virus, we were able to establish, or he was able to establish, the existence of this class of viruses in humans. You have to understand that this first paper was rejected by about 10 journals because of the so-called Gallo rumor virus. Basically, at this point, no one believed that these viruses existed in humans, and because that type C virus in the previous paper may have been a lab contaminant, they said, that's just Gallo having sloppy lab technique. Well, it turned out that wasn't the case. It turned out this was a real virus, and it was published, and it opened the way, as you'll see, to rapid advances in this field. Importantly, it developed techniques that accelerated the discovery of HIV because we learned how to detect these viruses, to grow these viruses, and to do blood tests for them. And that blood test platform, as you know, is very important in the future. So we thank Bob Gallo for his perseverance, and I think that's another important lesson, that often when you're at the forefront of discovery, and he was talking about this innovation issue, you have to persevere in the face of criticism, in the face of derision, and so on and so forth. He was not someone who was highly respected at that time, but he certainly proved his mettle in the long run, and he's been that way all along. So this led to a pivot in my career, and that pivot took place when I was invited to go to the UK with Bob, accompanying him, and I got to hear a talk that he gave where he revealed a lot of information that I wasn't aware of. He hadn't shared in the lab meetings and so on and so forth. In that talk, he showed the picture of that patient that we had shown before, the man who the virus was first discovered from. And this guy, Brownwell, who's one of the authors on this paper, came up to him afterward while I was standing there, and he says, that person doesn't have mycosis fungoides, which was the disease that he was diagnosed with. And that was a trigger in my mind. I said, well, this is interesting. Maybe it's a new disease. And so sometimes casual conversations can lead to insights if you sort of let your brain percolate information. The second thing was that he had, Katowski had these patients in the West Indies, and so we found that there were high titer antibodies to this virus in these cases from the West Indies, and also we learned from cases that Gallo had tested from Japan. And so we said, well, this is interesting. There's something going on. And so I sat down and spent about 6 or 8 hours writing a memo to myself, in essence, laying out my career path for the next 5 years. That was kind of unusual for me, but it really provided the guidepost for developing a series of studies. And so the next episode, it pays to be able to read upside down and also spend time in the bowels of hospital charts. And so I was doing some genetic studies at that point. I went over to the Red Cross over there in Bethesda, and I was talking to one of the scientists there because I wanted to get him to do some tests on some of the families, genetic tests. And I happened to notice some papers sitting on his desk, and they were data from the West Indies from blood donors. And so I kind of said, this is an opportunity. So I kind of shifted the conversation to say, well, you know, I'm kind of interested in the West Indies. You know anything about the West Indies? Oh, yeah, I happen to be studying this. And so that led to the access to available samples, which allowed us to prove that HTLV was endemic in the region of the West Indies, like it was in Japan. And then I went to the charts of all these patients that we were getting the virus from, and lo and behold, they came from the West Indies. So anyway, you have to kind of put 2 and 2 together sometimes, but also take advantage of the opportunities that come along, and use your noodle to figure that out. And so we undertook a series of Caribbean studies. Barry Hanchard, Nigel Gibbs, Courtney Bartholomew, and Courtney's young student, Farley Cleghorn, made up the main team in Jamaica and in Trinidad Tobago. And so these studies really led to some seminal insights, which also helped to inform the work that we subsequently did on HIV. We discovered that the modes of transmission were from mother to child by breast milk, sex from male to female, with male to female being greater than female to male. And we found that sexually transmitted diseases amplified the transmission of this virus. And these are all patterns that actually play out when you look at HIV. We also documented the high rate of adult T-cell leukemia in patients who had infant infection. And we know from our HIV studies that infants and children have a much worse outcome from their viral infection. We also showed that like 60% of all the lymphomas in the West Indies are due to this virus. And we also confirmed the linkage of HTLV to neurologic disease. Again, HIV is a neurovirus. We discovered a new disease called infective dermatitis. It probably occurs here in Nigeria as well. It's a disease of children infected with HTLV who are prone to not being able to clear saprophytic bacterial infections. And we also were able to use our Caribbean connection as a research bridge to jumpstart the research when we transitioned to IHV Baltimore. And we developed an international training program that directly benefited the development of IHV Nigeria. So shortly after the work we were doing on HTLV, these two MMWR published by CDC revealed the emergence of a new disease. We didn't appreciate the extent of it at the time. Green eye and sarcoma. Now, it happened just by coincidence. Let that get fixed before. Okay. 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 Can we fix the whatever's going on with the speaker there? Okay. But anyway, I'll just talk over the noise. So anyway, again, coincidence plays a role in life and science. Jim Geddert was a young clinical investigator who had just finished his training at Georgetown, and coincidentally had seen one of the first capsular sarcoma patients that was published in the MMWR. And so he had an interest in this issue. Bob Bigger was a international viral epidemiologist who joined my team, and Dean Mann, an immunologist, formed the collaboration that we then used to focus on our HIV research. By, again, serendipity, because of my cancer research work, I was interested in studying the immunologic aspects of cancer and had this fax machine. Now, this fax machine took up a large room and required a table that was earthquake-proof to keep the lasers stable. These things now sit on like a toaster on a desktop. But by coincidence, this machine arrived about this time, and I was able to repurpose it to start using it in our HIV studies. And so, being the first epidemiologist in the world to have a flow cytometer, I was able to discover in our cohorts that Bob Bigger and Jim Geddert set up of high-risk men who have sex with men, that there were very, very high rates of low CD4 counts, which we called pre-AIDS, in these cohorts and in hemophiliacs. At that time, people were focusing on the disease and not on the population. And so we were one of the first groups to document this high rate. And we collaborated closely with the Gallo team in the discovery of the cause of AIDS. And because of our pre-existing collaborations, we made seminal contributions to the cause of AIDS, its modes of transmission, and its grim natural history. We also published the first peer-reviewed paper on the sensitivity of the HIV blood test. And instrumental in this were Carl Sachtinger, Marjorie Robert Guroff, Dr. Sarangan Heron, and Stan Weiss, who did the blood bank work with us, and of course Bob Gallo, a younger Bob Gallo. And so in May of 1984, there were 4 papers that were published in Science that basically proved the cause of AIDS. Dr. Gallo and his colleagues. Within a few months, because of our connections to the blood tests and so on, to publish this cohort study that showed a minimum incidence of around 5% of AIDS per year. And we documented the rate, the importance of frequent anal intercourse and multiple partners in the occurrence of HCLV3. And so this was one of the first papers, if not the first paper, to show some of these patterns. Secondly, within a year, less than a year, we published the first peer-reviewed paper showing the sensitivity and specificity of in a peer-reviewed journal, of the of these HIV antibodies in the blood test, which then contributed to the licensure of multiple blood tests which were necessary for dealing with the blood bank issue and finding the extent of the epidemic. And we then, a few years later, in Science magazine, were able to document the natural history of seroconversion from, in an untreated population, from infection to disease, and showing that this virus, like other retroviruses, cause diseases of long latency. So in the meantime, I'm very blessed with the family, and we started off with Mike and Mary, with twins. We got off to a good start, and then John, Matt, and Tim. And we had a good time. Here we are heading down to, as a family, to Trinidad and Tobago. And so we've always felt that our family, as you'll hear later, should be involved in some of our international work. Another aspect of my, and really central to this whole life story, is faith and science. And often people don't see faith and science as being something that you connect to each other, but in fact, they're very integrally involved. So in 1980, after a long search, I came into the Catholic Church. And over my career, this faith has given me strength and balance and perspective. And that's very important. You got to have a life beyond the lab. I also find that the Holy Spirit enlivens my creativity as a scientist. Often my insights come in some way that's almost a spiritual experience. And so it does confirm that really everything we have comes from God. I even was martyred once by the New York Times, who almost got me fired from NIH following a talk I gave at the Vatican in 1989, where they came up with quotes that I didn't make because I didn't talk to any reporters saying that I was against the use of condoms, which I actually was pro-condom. And most importantly, it gives me eyes to see Christ in the dignity of every person that we serve, and to not judge their circumstances, behavior, and beliefs. And I think that's been a very core issue here, and core aspect of the success of IHV Nigeria, as they've treated tens of thousands of people. I think as physicians and as scientists, the dignity of every person is at the focus of what we do. And this is just a picture of us down in Trinidad, and then we had the opportunity to see Pope Benedict. I'd also like to take a moment to recognize that during our life story there are tragedies. And not too many months after we started IHV Nigeria, we lost a dear soul, Daniel Dockham, who died tragically from an infectious disease. And a few years later, I lost my son. And more recently, we lost one of our beloved colleagues. So I'd like to also dedicate this talk to them and to the staff here at IHV Nigeria who passed during their work. So getting back to the storyline of the Institute in my career, back in 1995, the so-called Dream Team established an Institute of Human Virology. And this required that I be reborn as a scientist, because at NIH, I got money, I did research, and then every 5 years I had to defend what I'd come up with in order to receive new funding. Now I had to turn myself 180 degrees and learn how to do the opposite, to sell my ideas to get the money. So I was actually the first IHV employee. I can remember driving up the road, feeling a little bit overwhelmed in September of 1995. I asked myself at that time, why did I leave that plush job at NIH where I had great bosses, limitless resources, and a very comfortable life? Well, my motivation was I wanted to move beyond understanding HIV/AIDS. I wanted to start solving it. I wanted to pursue the interface of population and vaccine trials. A former trainee of Gallo's wondered if I was crazy for joining forces with him. I mean, he's not the easiest guy to work with, if you want to know the truth. But I think successful people are that way. And I took a leap of faith and found myself on a precarious cliff face with no footholds. And so sometimes your greatest challenges require you to take that leap of faith. And I would encourage these young scientists here to go by your gut in some ways and go by your belief in yourself. And Dr. Gallo's vision was for a small epidemiology public health division. And beyond salary, I was left to figure out how to fund my research. So I had to adopt a new role as grant writer rather than creative scientist, strengthening and enriching my creativity. It actually enriched me, albeit a difficult and painful transition. I got a successful vaccine trials unit grant, but it proved to be a false start. And frankly, I failed at science by committee. But God had a better plan. And so sometimes you get on these path A, and then you realize that the detour is the road. So God kept building a team, and when formed, he opened new doors to allow me to contribute to the solution. I had Farley Cleghorn, who then joined me from then. He came to the Institute with me, and it allowed us to leverage some of the resources that we had developed at NIH to start funding the work we needed to do. We were blessed when Lashley allowed herself to also be reborn in some ways from the immunology lab into the wonderful work that she's done. And then there was this young fellow with an unusual name, Manhattan. He was named because I think he was born in New York, and his dad looked across at Manhattan and said, "That's a good name." And so Man comes driving up to work in this little sports car. I think he still has it. And now he's a family man, so I don't know. Maybe he's saving it for his son. But anyway, it was just amazing how people come together and we formed this team. Now, while all of this stuff is going on in our work, there's this path of discovery that is taking place that led to the development of highly effective antiretroviral therapy. And over time, this science led to the development of multiple different types of treatment, which have greatly transitioned from the 20 pills per day that people were taking now to a single pill in many cases, which has made possible the public health transition of really treatment as a preventative and treatment as a life-extending situation. So when we started, people were dying 1 to 2 years after their diagnosis. Today, they're gaining a full life. One of my first experiences with this here in Nigeria took place up at Faith Alive up in Jos, where this young woman was really on death's door. And with the availability of antiretrovirals, she was fully restored to health. So how did I get involved in Nigeria? Well, there was this fellow, Nasidi. I don't know if he remembers this or not. I think he does. Anyway, I had this master's student, Abidada, whose father was, I think, a minister of health, maybe, or something, back in the 70s and 80s or whatever. And she was a Hopkins student, and I was working with her. And so we organized this study with Dr. Nasidi and other colleagues to survey sex workers in Lagos. And this was at a time when the belief in West Africa and Nigeria was that the country was immune to AIDS. And what we found was that, in fact, this virus was to visit Dr. Abimiku's plasmaric lab, and Dr. Nasidi and his team intercepted me at the airport, and we had an opportunity to get to know each other in person. This began a long friendship that yielded good fruits in the early period as he and Elashi introduced me to the key players and resources. Also, I realized that the new capital of Abuja held great promise as a home for the future research institute because of its location and because sometimes when you start in a new place, there's new opportunities. Finally, Dr. Nasidi arranged a rather hastily arranged talk to the Minister of Health and his staff, which awakened a sense of urgency to bring treatment to Nigeria and to participate in the research to advance the science, including vaccine development. And this is the first slide from that talk, which I gave at the Federal Ministry of Health in July of 2002. So in 2003, President Bush started PEPFAR, which began as a $15 billion program to bring treatment to hard-hit sub-Saharan Africa and a few other countries in the world. And so, inspiration and support. Well, my family has been very important. And my son here, Matt, was in Boston College, was looking for something to do in his winter break. And so I arranged for him to come with me on one of my trips to Nigeria, and we went up to Jos to Faith Alive, and he volunteered there as a data person, helping them develop their data system. Well, he was so touched by his experience at Faith Alive that he said, well, I'm praying, Mom, that you come to Nigeria. The last thing that she wanted to do was get on a plane to go across the ocean, number one, and Africa, really? And so she said, you're praying for me, there's no choice. And so she recruited my son John here on the left, and Tim, who was like 14, I think, at that time, and then our neighbor, lady called Joyce Johnson, sent her daughter in the middle there. And so it was a pretty rough business because people were dying every day. And I can tell you for a 14-year-old, it's pretty traumatic. And so one thing he did was to make a video, which we still have, of his experiences. Subsequently, my son Mike came and was instrumental in helping to develop some of our links with the high-risk MSM populations. And Diane had a heart for the orphans, and so she got very involved in the orphanages. And also, she had a rather pivotal role as we stopped off in Bauchi after a trip up to Yankari. We met with the governor, and as we were getting ready to leave, he said, is there anything else you'd like to say? And at that point, Charles and Patrick turned ashen when Diane stepped forward and said, we need to get rid of the 100 naira chart fee, which is stopping people from being able to get their treatment. And he said, yes, you're right. We're going to stop this in Bauchi. And she said, no, you need to go for the nation. And so he said, well, I'll talk to the president. And so hopefully that helped to change that trajectory. Now we have my granddaughter who's here for her first visit to Africa. And so we're very... And Diane continues to be involved in helping to support the orphans and those needy through the Hope for West Africa Foundation. So, launching IHV Nigeria in the summer of 2004, we were subrecipients of a USAID award to an implementing partner, and we were responsible for treatment and lab. And through the intervention of Joseph Norham, then CDC national epidemiologist in Nigeria, and some other events that we won't go into, involving Alashli and others, that portion of the USAID grant was transitioned to supplement that UTAP training grant, and thus we needed to establish IHV Nigeria as the vehicle. Now, my idea of IHV Nigeria was to not just have a project, but to have something that would be sustainable. And that was a vision that was very much central to Alashli Abemaku, who was on board from the beginning. She was instrumental in, we were up on the 10th floor of the Hilton, and Governor's suitcase was up there, and so she went on her knees and asked for Dr. Dockman to be released to allow him to join the team and ultimately CEO. Meanwhile, back at the university, Charles Mensa had left the parking kiosk and was doing bookkeeping. When he would sit out there studying his CPA books, and the lady in the thing goes, "Africa boy, what are you doing studying those books?" So remember that. And so then he became a university employee, and soon we seconded him to be a co-founder. John Verdefe joined the team shortly thereafter and has had a spectacular career. John Farley, infectious disease. James Shepard, who you heard from earlier, brought the high standard of medical quality. We had Maria Ang involved in adherence. Marianne Edebet brought new perspectives. Nadia, who's here, has been making very successful programs in mother-infant. Emilia Iwu was doing community work, and Joyce Johnson was busy cracking the whip, I guess, would be one word or the other, and Pacha Veladiego. So we've moved from a small team to now a very wonderful 500 plus team, 99% Nigerian. And we've had words from a number of our representatives from our board of directors. This is a very active board. This building, or these buildings, would not be here without the hard work of the committees of that board, who were instrumental in helping make the right decisions, and also in the auditing of the funds to make sure everything was done right. When I presented the concept of this institute to the University of Maryland, I envisioned an institute that would be here beyond PEPFAR and beyond what we're doing. We had, in my simple mind, three goals for this institute: research, training, and treatment and care. And you saw from Alashli's presentation how that's evolved. Initially, the university wanted to control everything, but I didn't think that was going to be the turned out actually to be a prescient opportunity to make IHV Nigeria its own entity and a partner rather than be controlled by the university. And so the fruits of this have been tremendous. We've developed over 1,000 sites, have tested over 15 million people. There are over 500,000 who've been started on treatment, and there's currently almost 400,000 currently on, according to the statistics. The activities of IHV Nigeria touch every state in the country in various projects beyond HIV, to include TB and nutrition and a whole number of wonderful programs that you'll hear more about as you attend some of the poster sessions this afternoon. One of the innovations that we did was to take our testing to the community. This white van was a important find. Charles Mensah, he went down to Lagos. We needed some vehicles, and he was able to negotiate a 2-for-1. Good Nigerian that he is. And so we got this van and a sedan, I think, out of that deal. Unfortunately, the van proved to be not roadworthy. I think it was a reject from Korea, probably. A bad design, because it would skid off the road all the time. And so I happened to be visiting one time, and this van was sitting in the parking lot, very dusty. And I had the idea, well, why don't we just drive it here in Abuja, and we put a little sofa in the back and set up our first mobile lab, and went out on the street and started to recruit the high-risk populations. Where are we now? Well, in collaboration with the University of Maryland and led by Man Sharat, there's over $53 million in grant funding, much of it coming from NIH and other groups. So from that small beginning, God has multiplied a bountiful way. Ashley pointed out, we're now starting that important transition to independence of the Institute as it develops its own scientific staff. And Ashley is developing a wonderful cadre of young scientists who are writing their own grants. What has been the impacts of this program? Well, people living with AIDS is going up. Why? What does that mean? That means people are not dying. That means people are living with HIV. We've turned the trajectory from 2000, where the population was actually dying off, to now, with PEPFAR, going up. We've seen the number of infections going down dramatically because of the treatment and the achievement of the 90-90-90 goals and suppression of virus across the country. Globally, antivirals were immediately impactful in the early 90s, in the mid-90s, when the drugs were first available. There was a really 10-year, as you can see on the slide, before the drugs were available in Africa to have the same effect. And that speaks to the importance, such as Nigeria, looking out for the goals and the purposes of the people serve, so that those research outcomes are more directly available. So the future home of IHV Nigeria started in 2012 when we made a site visit to this very site. And there was a little Fulani village right on these grounds that we had to help them find a new place to live. And we're looking at all the different parameters. And then the board came as the site was broken, and then further construction, and now where we are. So the future of HIV, I think a big challenge is sustainability of worldwide treatment for in the post-PEPFAR region, because we're in a period of transition. Currently, for Nigeria, there's 530 basically $500 million out there. And right now, the government of Nigeria's contribution is 91 million. So there's a huge hiatus that's going to have to be filled somehow if PEPFAR is going to be transitioned. And that's really the major challenge that we have, is to make sure that the resources are available, because we have all these people that were living with HIV, but they have to have the drugs. There's a continued disparity compared to men. And so as we see here, the trends are not so favorable from the point of view that there's still very high rates in young women and also in young men. And so we have to start to somehow change that trajectory. Otherwise, we're going to have a reemergence of the pandemic, because the young people are going to drive it. We have a continued outcome gap between adults and children. They improve the treatment outcomes in young people. Infection in key populations. Here is a flat curve, basically, which means that we're not impacting the trends in MSM compared to the general population. And so if we're not able to control it in these key populations, we also have that potential for a continued epidemic. Shortened lifespan despite treatment. And this is a fairly complicated slide I'm not going to go into in detail. It's just published about a month ago. But basically, the different lines relate to the CD4 levels at diagnosis. And basically, you can see that compared to the top line, that even in the best CD4 group, that survival is not as good as in the general population. And so we still have work to do to overcome the barriers, particularly of these comorbid non-communicable diseases, long-term consequences of children who are exposed to HIV, who have effects of that virus. My own opinion is that the cure in the short term is a complex issue that's not going to be solved. And as Dr. Gallo pointed out, the current approach to vaccine development is not likely to yield an effective vaccine. So I'll finish up with a few personal reflections. What are the lessons of my 40 years of doing research taught me? First, trust in God. He has a plan, and doors open when you are on his path. And you can see that in the fruits that we have here. Second is act in humility. It's about the teamwork. It's not about you. Opportunity, not by following the crowd, possibilities. Adversity, strength, iron sharpens iron. And so you can't let that adversity stop you. Take strength from it. Hire good people and invest in them, especially rewarding those people with the use of that. It's very important to invest in the younger generation with opportunity and resources. I wouldn't be a seniority trap that holds back promoting the best and brightest, especially the talented young person. Most importantly, retire before the light becomes dim. And it's very important to nurture your successor. He or she will outshine you, which is a good thing. Look at what man has done. Much more than I could ever do. And finally, your legacy is the fabric of people who have touched you and you have touched. Thank you.
this.
Yeah,
just a minute. We're going to take 5 questions because this is a plenary session, and this is our keynote address. So please, just 5 questions, and then we will have a break. Please, yeah, please go ahead. Yeah.
Well, is it afternoon yet? Yeah, good afternoon, everybody. I just wanted to say 1 or 2 words. I can see my second half here, talking very emotionally without bringing some few points. One, we have all been hearing that behind every successful man, there is always a woman. I came to understand that when I met William Blattner and his family. I think I have learned so much from him, but then if you say these are the founders, co-founders of IHVN Nigeria, or IHV Nigeria, she is our founder, she found us. She is our founder. She has done so much. Please, I think I have never seen any foreigner or group of foreigners that love Africa and Nigeria like the Blattner family. I think this is something. Let me just quickly round up. When I met him, I had a wife. She's passed on, may her soul rest in perfect peace. She died as a Christian. I'm a Muslim, my wife was a Christian. And the first time she saw Blattner, she looked into his eyes and said, "This is a sincere man, you can walk with him." Praise the Lord. So the story could be long, let me cut it short. We started with him, as he said, when I hijacked him from the airport, and when my wife gave me the directive to move on, and I trusted him fully, he trusted me fully. And we started with some resistance, but we established what we call the Asokoro Project. From the Asokoro Project came 3 institutions led and moved by great young Nigerians. The IHV Nigeria, moved by Alashile, Daukum, and Mensa. Then the CDC Nigeria. That time we said with Blattner that, look, why should we be just waiting for the event to happen, just like the NCDC DGs mentioned? Why are we waiting for it to happen? Why don't we actually be prepared to meet it? So we said, let's get to you. Anytime we have outbreak, US CDC are coming with their liquid nitrogen tanks and everything. We said, no, if you want to help us, let's do it here. Let's establish CDC Nigeria. John Vatafe was a student, he just finished a PhD, all this, and so we thought he could lead that institution. CDC Nigeria, US, based in Nigeria, has been helping us and has reduced our response time instead of waiting for too long. So if we have outbreaks, our response time is reduced. We mitigate the impact of such outbreaks, and we have done very well. The third institution that came out of Asokoro Project is the Nigerian Center for Disease Control. Jointly with Blattner, we established what we call National Clinical Research Training Center, NCRTC, and we kept pushing that project with Professor Harry, Professor Blattner, myself, until we got finished. Praise the Lord. So this is Adria. We thank you for all you have done for us. Thank you very much.
Thank you. Thank you.
Sorry, I forgot to mention Manhattan. You know what Manhattan is in New York? Oh yeah, a young man came called Manhattan, and he rose to be my boss. Thank you.
Please make sure you come to the gala night and the commissioning. You'll get a lot more of this. But we will take 5 questions or comments to Professor Blattner now. The young one shouldn't be shy. He did mention that.
There you are. Please introduce yourself and use the microphone. Thank you.
I'm Rachel Abuja from News Agency, a public health journalist.
I'm sorry, say again?
I am Rachel Abuja from the News Agency of Nigeria, a public health journalist.
Wonderful.
Yes. Now, thank you very much, and thank you for the work that you do. As a journalist, I found out that most Nigerians have faith and don't believe in science. When you tell them to take drugs, they'll tell you, no, we are waiting for God to intervene.
Mm-hmm.
Now, my takeaway point for me here is you bringing in faith and science.
Mm-hmm.
How will you explain that to some Nigerians who claim to have faith and don't want to have science?
Okay.
In order for them to put everything together,
Okay.
for it to work for them.
Okay.
Thank you very much.
Okay, I have a question for you. Where does science come from?
Some persons will tell you no. Let me say, some Nigerians will argue with you and tell you science actually came from a white man.
No.
So, yes.
But God is not white. All knowledge comes from God. And so science is a gift from God. In his mercy, he allowed these drugs to be discovered. He gave us that ability. And those discoveries, he gave Bob Gallo great gifts to be able to discover things. And there are people in this room, young people, that he's given great gifts to. And it's a matter of using those gifts. And for the people in the community, they need to pray to God that he will, in his mercy, have science be an instrument of their benefit, and that those discoveries are coming from God, and that they should not ignore what God has provided.
Thank you.
One over here. One over here, yes.
Yeah. Okay. Well, he's there.
Yes. So I'm a Vaisi. Just to ask one question. Okay.
Oh, there you go.
Okay, great.
I'd like to see who I'm talking to.
Yeah, I'm really impressed by your drive to give chance for younger investigators. I'm just wondering, how do you define, or what qualities do you expect from an aspiring young investigator, fit into the vision you have? I do Professor Mann and how you nurtured someone. Just generally, not specific to him, but generally, what do you see that can be a force to say, well, this individual, this young person could be nurtured in a direction?
Well, but not every candidate is going to work out. And so you have to take a chance. I think you start, as we have with our Fogarty program, standard. We realize that quantitative ability is an foundational quantitative capacity, because you really want to be objective in the science. And then you try to have sufficient resources to have a pool of people. I mean, when I was a clinical associate starting out, there were probably 5 of us. I was the one who stayed on for 22 years and had a career. Other people went on to private practice and to provide treatment to people and so on. So not every person that you identify is going to do that, but their experience is going to positively impact their benefit to the people that they serve. And so the win-wins are when you find the person with the right stuff. I think also probably some intangibles that are often tangible in terms of their willingness to go the extra mile and show that they're willing to go to the literature, to scholarship, and to be able to, in some ways, challenge me with the facts that they can come up with. And so you have to have that ability to do your homework. And obviously working hard is important, as Diane can testify, that sometimes you're working long hours. But I did try to get home to dinner every night with the family, and then if I had to work later, I would do work later. But usually I didn't, and it worked out fine.
We're going to come back here, but I wanted to give an opportunity for a question from that side. There's a gentleman at the end there, please. Go ahead.
Sir, and it's a pleasure to be back in the team. My question has to do with, we've seen the funding gap. Speaking from outside in to the country, how should the government folks prioritize health to the point where they actually, not just plan expenditure, but they actually vote? What else do we need to communicate to the government folks to prioritize human capital, to deem it fit to actually fund and release the actual funding required for stemming some of these terrible tides that we're seeing if the gaps are not met up with?
Well, I think that the health of a nation is the health of the country. A great nation has to be able to have a healthy people in order to have productivity. Obviously, you have to have education, and that education needs to include education on health. And what I mean by that, a healthy lifestyle, because many diseases are related to poor hygiene and, as you know, from infant mortality and so on. Now, how to get your funding? I think it requires integration of healthcare services. You can't have a balkanized system where one specialty is separate from another. You need to be able to provide holistic care, and you need to achieve efficiencies by training and empowering other members of the healthcare team, particularly nurses and other paraprofessionals, to have greater capacity and greater ability to contribute. My wife, Diane, is a nurse, and she was one of the first chemotherapy nurses in the U.S. Giving therapy. In the past, we physicians, I'm an oncologist by training, had to do all this stuff. And nurses do it much better and with greater precision. And so you have to expand the access of people by having a cadre of pharmacists, nurses, and other paraprofessionals contributing to the healthcare team so that you optimize the efficiency. Okay. Man over here, man after my own heart. Cancer.
Thank you very much. My name is Dr. Adamu Al-Hassan Umar.
Nice to meet you.
I am the president of the Nigerian Cancer Society. the youngest president ever in over 58 years.
I'll have you go after him.
In over 58 years of the existence of the Nigerian Cancer Society, the Nigerian Cancer Society is the umbrella organization for all cancer-related NGOs in Nigeria. And I am a young researcher. I have been a cancer advocate for over 20 years and counting. And sir, today, your presentation has truly given me a lot of lessons. And I'm not standing up here to ask a question, but I just want to pass a comment. As part of the lessons learned, and one major lesson I'm learning today is where you say, see opportunity not by following the crowd, but by seeing new possibilities. And all along in my life as a public health physician, I have been working on the mantra from the saying by Winston Churchill, where he said, an optimist sees the possibility in every difficulty, whereas a pessimist sees the difficulty in every opportunity. Now, your presentation today, sir, has given people like me hope that we can start small and grow big. And it is only a matter of time. And one last prayer, sir, that I have is that I pray, it will be my take-home prayer from this gathering here today. I will go home and start praying today that I hope and pray I will be a mentee of yours before you retire. Thank you very much.
That's wonderful. Thank you. I think that one of the things that I would point out is that there is tremendous intellectual energy here in Nigeria. There's tremendous capacity. At the University of Maryland, one of our scientists discovered an important drug for cancer called aromatase inhibitors. And the scientist who actually was the major leader along with co-leader on this project is Nigerian. And you'll see over and over around the world where Nigerians who have been in the diaspora have made tremendous contributions to the health of the world. And there's no reason that Nigeria itself, with the proper investment in the education and in the infrastructure, such as Dr. Bemeku is starting to develop here with world-class laboratory equipment, that Nigeria itself cannot take advantage of its intellectual capacity to be a leader in the world. Of course, it's going to require commitment on a lot of different levels, but the potential is there, and we have great hope for that.
Professor Blatt, just one more question, if that's okay.
Yeah,
please.
yes. Yes, well, nice to see you, chat later. My name is Felicia Phillips.
Yes.
Just linking to the previous question about government's role and participation. I just thought, what are your ideas and suggestions on how we can get the private sector to play a greater role in the scheme of the kind of discussions we've been having today? I know that when we had the COVID outbreak, the private sector, especially the banks, they raised billions of naira towards trying to provide some safety net and a whole ecosystem, so to speak, to deal with the COVID pandemic when it turned up. But how can we, what should we do to try and get the private sector to join in this game?
Well, one thing that comes immediately to mind is the Gates Foundation, which is a foundation that was developed by the Microsoft head. And he has taken some of the profits that he's made and created a foundation that then provides grants to support public health around the world. And so the private sector in Nigeria could also start to develop its own Gates Foundation. And then using competitive processes to identify the best and brightest and in Nigeria, create funding opportunities for them to work with one of the universities or institutions like IHV Nigeria to develop their research career or to pursue a project that would have particular benefit to the people of Nigeria. I mean, there's tremendous public health issues related to malaria, tuberculosis, infant mortality, that require innovative. These are problems that have a way, and all the international stuff hasn't had the impact that we're hoping for. And so it's going to us, Nigerians, to really bring the innovation that Dr. Gallo talked about. It doesn't necessarily come from science by committee. It comes from who understand the problem and bring new approaches to the problem.
So I lied. One more.
Okay.
Okay, thank you very much for the very interesting talk. My name is Nuhu Dakum. I'm a professor of surgery. And there are a lot of lessons from what you have said, talking about science, faith, family. And it's very obvious that you're a great family man. Now, achieving a balance between all this could be very difficult. And once the family is not well, your work cannot go well. So what would be your advice to the younger scientists on how to achieve a balance? What motivates you?
Well, you start with a prayer. Because you really need energy to be able to do that. Now, as Patrick knows, I'm a very low energy person, and rarely call at the midnight night. And so I think that it's not how much work you do; it's how much work that is on task for the project and for the goal that you have that counts. We spend an awful lot of time on peripheral issues and waste a lot of time. And so if we stay focused on the goal, we have plenty of time for our faith, for our family, and for our work. Just keeping of thought and maybe less time answering irrelevant emails on your phone.
Please join me to thank.
Just 1 minute. Thank you. Thank you, everybody. One last minute, and then we will all go for a break. And remember, after the break, we have roundtable discussions, which is going to involve you. You'll have an opportunity to be really part of that. And then we will talk to our industry partners, some of the questions that Sir Phillips has already brought up. But I don't want us to lose an opportunity. We heard, please be seated. Thank you. I feel like I'm in the church. Maybe I should have just let you stand. But before we break, I don't want to miss an opportunity. You heard what Professor Nasidi said. Behind a papa is a mama. So we must hear from our mama, and then we can cut for the break. So please, Mrs. Blattner.
I have no idea what I'm going to say. I just want to say how much I love the Nigerian people. You've always made me feel welcome, and you've increased my faith because you pray. I can tell that you love God, and you love each other. And I just, I'm so grateful that I had this opportunity to come back again after 15 years, and also to bring my granddaughter Maya, because Maya has great potential and she will use the beautiful way, I'm sure. So I just want to thank you for her and the love you've given us. Through the love you've given him, he gives it to me. So pray, I will pray for all of you. So thank you so much.
Thank you so much. Thank you, everyone. Tea is being served. See you in 20, in 15 minutes, please. Thank you.
Okay. Oh, that's the professor you're talking about.
When he's coming down, because he tends to go this way.
Hello, everyone. Please, hello. Just a minute, please. Hello. Please do not forget your phones behind. Please move with your phones.
Where is she?
Yes.
You didn't tell me. You didn't tell me. I would have told them all about you. Wonderful little girl with a permanent smile. So when you were talking about me, I started out with microbiology 101.
That's true. That's right.
Oh, you are leaving. But I'll go to the gallery. Yes, okay. I wouldn't have missed it for the world.
If you want to bring out that one, I am. All of the UPS. Wait, they came, I came together. They came, we're not moving together. Yes, mute. It's minutes.
Check, check, check. Excuse, come off your phones. Hello? Check, 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 check. Check. Testing podium, 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 podium. Check. So this one is not on. But this one's that one. Mic check, 1, 2. Mic check, 1, 2. Testing 2. Okay, excuse. So now I'm going to finish. Check, 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 check. Check. Mic check, 1, 2. Mic check, 1, 2. Mic check, 1, 2. Line check. Podium mic check, 1, 2. This is good now. See, this one again. Check, check, check. Mic check, 1, 2.
Check,
Mic
check,
check,
check.
1, 2. Testing.
Check, check, 1,
Testing,
2.
testing. Okay.
Check, check, 1, 2, 1, 2. Check, check. Check, 1, 2. Check, check, check. 1, 2. 1, 2. Check, check. 1, 2. Check, 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 check. 1, 2. Check, 1, 2. Check, check. 1, 2. Check. No, so was the check 1, 2. Check 1, 2, 2. Check, 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 check. 1, 2, 1, 2, 2. Check, check, check. 1, 2. 1, 2. Hello. 1, 2. Check, check, check. 1, 2. Check, check.
You can send this one to this. This one will be for display settings. Display settings for this. Send that for me. Okay.
Check, 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 check. Check, 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 check. Check, 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 check. Who dey control this one? Keep the mic.
Dead person one day.
Check, 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 check.
So I believe visual blind person.
This one is on. Check, 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 check. My mic is on the other side. Check. Check, check, check. Check, check, check.
Okay. You go for that thing.
Check, 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 check. Check, check.
Check, 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 check. 1, 2, 2. Check 1, 2, 2. Check 1, 2. Hello. check, 1, 2, check, check. 1, 2, 2, check, check, check. Check, check, check. 1, 2, 2, check, check, check. 1, 1, 2, 2, 1, 2, 2. Hello, check, 1, 2.
Check, 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 check. Check, 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 check.
Check, 1, 2. Hello, check, 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 1, 2.
Check, 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 1, 2, check, 1, 2, check. 1, 2, check, 2, check, 2. Two, two, two.
Check, 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 1, 2. Check, 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 1, 2. Check, check, 1, 2. Check, check, 1, 2. Check, check, 1, 2. Boss. Check, 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 1, 2. Check, check, check. Very clear here, sir.
Check, 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 1, 2. Check, 1, 2.
Check, 1, 2. Check, 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 1, 2. 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 Check, 1, 2.
Check, check, 1, 2, check, 1, 2.
Hello, hello, hello. Testing, 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 testing. 1, 2. Testing, testing. 1, 2. Okay. Check, check, check. 1, 2. Check 1. Check 1, 2. Check 1, 2. Check 1, 2. Check. Check 2. Check 1, 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 2. Two. Check 1, 2. Check 1, 2. Check 1, 2. Check 1, 2. Check, check, check 1, 2. Check, 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 check. Check, 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 check 1, 2. 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 Check, 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 check. Check, check, check. Check 1, 2. Check 1, 2. Check 1, 2. Hello. Check 1, 2. Hello. Check 1, 2. Check, check. 1, 2. Hello. Checking the mic. 1, 2. Check, 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 check. Check 1, 2. Check 1, 2. Check 1, 2. Check, check 1, 2. Check, check 1, 2. 1, 2. Check, 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 check 1, 2. 1, 2. Check, 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 check 1, 2. 1, 2. Truck 2. 1, 2. Truck 2. This mic. Check, 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 check. See again. 1, 2. Checking the mic. 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 Check 1, 2. 1, 2. Check, check, check. 1, 2. 1, 2. Still, what do you sound like? Check 1, 2. Check, check, check. 1, 2. 1, 2. Check, check, check. 1, 2. 1, 2. Check, check, check. 1, 1, 2. 1, 2. 1, 2. 1, 2. 1, 2. Check 2. 1, 2.
Please take your seat, everyone. We're about to start. You don't want to miss out on the roundtable discussion. This is when we have an opportunity to hear from you as well. Apple and finish up in the room, but we're going to get started really. I guess you're, okay, I see your other panelists. So thank you. Welcome back. Welcome back at the back. Welcome back at the back. Welcome back at the back. Okay, we're ready to start, guys. Mike, Mr. Mike. Mr. Mike. Mr. Mike. I can hear your voice, so I'm trying to get us going. All right, this is great. So we're going to have two roundtables, and this is an opportunity to really interact with the audience, like I said. The first roundtable is going to be chaired by Professor Man Charurak, and he'll introduce the topic and introduce the panelists. And then after that, we're going to have the second roundtable, which will be chaired by Dr. Oyemeta. And that's the one that engages our private and industry partners. So welcome back to the session, and thank you, Professor Charurak, for flying all the way from Baltimore.
So I've been asked to moderate this session. The topic is vulnerable population. And let me tell you why Prof. Lashley decided this is a critical topic. What is the mission statement for IHVN? To be a center of excellence in providing health services implementation and research in ensuring equitable access, right? So the word here is equitable, and health equity is important as this time point in Nigeria, and because of that, no population can be left behind. A common saying is that HIV anywhere is HIV everywhere, right? I would say that infectious disease anywhere is infectious disease everywhere. So to help this discussion, let me welcome the two panelists that's going to be joining us. So let me first introduce Dr. Sylvia Adebayo, who is the Country Director for University of Maryland's program here in Nigeria. She comes from a long line of experience in working with key populations, especially with sexual and gender minorities. Welcome, Dr. The second panelist, I want to welcome Dr. Nadia Samagudu. She is an assistant professor, associate professor at the University of Maryland School of Medicine, and as you know, a senior technical advisor on pediatrics. Welcome, Dr. Samagudu. So, Dr. Nadia, as you may know, have been working with children, with little people, especially with adolescents, right? She is also, from context of the NIH, is the Implementation Science Alliance, who were on dealing with issue with adolescents. So obviously, there comes with deep root subject matter expert that I will around how do we reach with adolescent and sexual gender minority who oftentimes vulnerable to HIV, vulnerable to not getting access, and some vulnerable because of either policies or legislation structure that have been put in place that prevents them being access to both research and health services. So with that, let me ask Dr. Adebayo, from your experiences having worked with sexual gender minorities in Nigeria specifically, what do you see are some of the challenges, but also some of the good experiences and lessons learned that we could help talk about addressing these gaps?
Thank you very much for inviting me to this panel of discussion. A very interesting topic. With sexual and gender minorities in Nigeria, I would say that we have come a long way. Starting from a time when sexual and gender minorities were discriminated against. They weren't regarded as Nigerians or that they existed. But we've come a long way to a point the Nigerian government has come to accept, that they do exist. And so the policies have changed over time. Goodwill has improved. However, we still have the stigma and discrimination, which is very rife. And so this has led to so many things, including the Same-Sex Marriage Prohibition Act that became a law in 2014. And since then, the Nigerians who are sexual and gender minorities still remain there. They still remain Nigerians, but they've gone underground. And they still will do what they need to do because they are human beings. And so that's one of the bane of the problems that we have, which is sexual stigma and discrimination, homophobia, both internalized and then homophobia from healthcare providers. And so what happens is that this actually hinders access to healthcare services. Healthcare providers don't have that index of suspicion to know what their needs are. And so when you start off that way, the members of the community don't have the opportunity of being expressive and to say exactly what they want to say. So they couch whatever their presentations are, in different ways. So that is one problem that we do have. And then there's the other point about definition of, their characteristics, the typologies, and so on. Some of the definitions we have, just accepted from all over the world, but then the Nigerian definitions, those are some of the things we need to also come up with, because sometimes when we call some people sexual and gender minorities, some people may actually not want, to identify with that. That in itself becomes a problem because some people will be left out, and then poor quality of data. We are funded by different funders, and of course, by being funded means that you are data driven. You are given counts and so on. Sometimes outrageous targets that can be met, and so what happens is we do know too that the quality of data may be questionable, and that becomes a problem. That the data we have, are we sure that they're actually sexual and gender minority data? Because if we're not sure of that, that becomes a problem in itself, because we feel that we are providing care and improving access, yet from the data we are seeing, the HIV incidence is still increasing in this population. So are we actually targeting the right people? And so what we need, all this, and then of course, one more thing I shouldn't forget, measuring the size of the population.
Right.
That becomes a problem. If you don't have the denominator, then how are you sure you can even measure the impact of what we're doing? So measuring the size of the population, that we don't actually know the size of the population.
Right.
So just make the assumption.
To be able to align programmatic responses.
That's right.
Without that's excellent. Before I go to Dr. Nadia, I also want to introduce esteemed colleague that's online is Prof. Nordu at the University of Abuja Teaching Hospital. She's also has been funded by the NIH to study sickle cell disease. She's also joining. Sickle cell disease is also considered, part of a vulnerable population, especially in Nigeria, where it's most heavily burdened. So welcome, Prof. online. So to Dr. Nadia, in terms of adolescent, what has been learned so far, either through studies or implementation, how to work with adolescent to have them better be engaged in either research or program?
So thank you very much. So when it comes to adolescents, I think one of the things that comes to mind immediately is the age factor. Adolescents are categorized as 10 to 19, that most of them are under 18, which is the legal age for many different things. So access to services becomes a problem with issues of consent, parental permission, whether it's services or research. Now, so what have we learned so far? especially looking at this from an equity and implementation science aspect. There's been an explosion of implementation research in adolescents, particularly with respect to HIV. And one of the things we are learning is how to better adolescents and not surface engagement or not temporary engagement, but really deep engagement from the beginning. And we recently had a HISA meeting, that's the Adolescent HIV Implementation Science Alliance meeting. That emerged from there was that we really need to look at them because they are young people. We also actually have to support them so that they can be great representatives in the one thing that some of us didn't really think about, right? Because when we are doing it and we are engaging, say, adults of different populations, the issue is the engagement, not whether they are ready to engage. But when you're engaging young people, many of whom are still in school trying to figure out their way in life, you actually have to train the young people as you are engaging them. So that becomes the foundation of how we do research, special implementation research from the get-go, engaging and doing, and there are now frameworks for how to meaningfully and engage and train adolescents as you are engaging them and as they are working with you.
That's a really good point. I think people oftentimes look at capacity building aspect when it comes to adolescent, and it's hard to not to talk to an adolescent being a parent, but I think we need to view them more as a partner in their journey to get either access to service or engage in the research. I think really good point. So let me turn over to Prof who's online. Maybe Prof Onodu can potentially talk maybe for 3 minutes about the work in sickle cell disease and the vulnerability that has been created, and what you have learned so far, and what are the current gaps that you are seeing for Nigeria. Prof, please. Can we?
Yeah. Thank you very much to stay here. I'm a professor of hematology and blood transfusion, and the work in sickle cell disease in Nigeria actually took on a new path in 2010 when we went to a global congress in sickle cell disease in Accra, Ghana. Before this time, most of the work in sickle cell disease were focused on small pilot studies from different institutions, and there was very little coordination among the investigators. But at the Global Congress of Sickle Cell Disease, we were actually changed into being the country to have a strategy and to plan for sickle cell disease. And so at that Congress in Accra, the Global Sickle Cell Disease Network was born. And one of the first things that we did was that we set priorities, national, to have a policy, to have a guidelines, to have a research agenda, and to also do a newborn screening. And we had different research areas of research called such as infections, hydroxyurea, the natural history, the phenotype, and how to characterize the diversity, led by having different baseline studies that described the condition in sickle cell disease, mapping out the facilities for the work, the blood transfusion practices, looking at the stroke prevalence, as well as attitude to newborn screening. And we got together and we had 39 clinical centers that were part of the network. And about the same time, the Center of Excellence for Sickle Cell Disease Research and Training was initiated by the University of Abuja. And after this, we started getting funding from the NIH, first for the Sickle Pan-African Research Consortium, which developed a registry that has over 8,000 patients in Nigeria now across multiple sites. So we have a registry that we can follow up people in that prospectively. We had a standard of care guidelines, and then we started developing skills of healthcare workers to deal with sickle cell disease patients. And then when we were 3 years into the registry, we there was high blood transfusion rates. Up to 60% of the patients were receiving blood transfusion, and there was very low utilization of hydroxyurea, a disease-modifying treatment. In fact, most of the evidence-based interventions were not being optimally used and were very low levels across these clinical centers. And then, so this is helping us to know how to work with the patient and how to advocate for these interventions to be provided. Like you know, sickle cell disease causes catastrophic health expenditure on patients who have it in their families because they have to pay out of pocket for most things. And then when we looked at why these interventions were low, we started seeing barriers from patients and their parents. We saw healthcare provider barrier out of ignorance, and then we also saw health system barriers to providing the quality of care that these patients required. Apart from the sickle, and then so the Sickle Pan-African Research Consortium is the infrastructure grant by the NIH that set out to build the infrastructure for future work in sickle cell. Along with this, we also have the Sickle Cell Genomics Network of Africa that has collected a cohort of 7,000 well-phenotyped patients for genome-wide association studies. Shortly after this, we also have intervention from the American Society of Hematology that set up a consortium for newborn screening in Africa and in 7 countries and in Nigeria, Kaduna State and Abuja. In Abuja, we are screening in 22 primary healthcare centers, finding babies and trying to bring those babies into care. And so what we noticed because of the barriers, we noticed that there is much need for implementation research. And so we have been funded recently by the UK National Institute of Health Research for a patient-centered management of sickle cell disease in sub-Saharan Africa. And this is to drive implementation research in sickle cell disease by providing the kind of care that the patients require. In recent times, we've also, because we now have the registry, we are following up the patients, we know those who are coming, we can track them prospectively. We have also started having a farmer coming, wanting to do clinical trials. So across six sites in the country, we have a number of clinical sites that are coming up. Along with all of these research initiatives, we are also developing skills in healthcare, in database management, and in order to be able to make some sense of the data that we are getting. So we have a network, the Sickle Pan-African Research Consortium is not just in the University of Abuja, but it's actually working out of a network of 25 clinical sites, very closely for the past 6 years, developing the skills and working closely together. And if you look now in the literature, you find that the work is we are describing, and then most of the work is high impact publication. We looked at diagnostics. We have a validated point of care test in order to be able to pick up the babies even in rural areas. And you see that our work is getting a lot of attention internationally, and they are multi-center multidisciplinary research that is coming out of Nigeria.
That's great,
And
Prof.
so there are more interest, these days in investment, also by the Nigerian government is a little investment in research. So these are some of the things that we are doing with patient with sickle cell disease. But as we know, in order to address some of the barriers, especially the patient barriers and the healthcare barriers, we are working with the media in order to educate the media to be able to put out messages to the patient with sickle cell disease, so that they are aware and they know what is available. Our colleagues also know what is available, and they'll be able to come and be a part of it. Thank you very much.
Thank you. That was really insightful, and definitely happy to hear the infrastructure that's built around sickle cell disease response. So with these now introduction from the panelists, I would really like to open up to the audience for questions that they may have, you maybe have, especially the up and coming young investigator on what other areas within these that needs to be tackled from your perspective. We also welcome to hear from your perspective as well. How do we tackle these high vulnerability population to better engage them in research and or in care? So don't be shy, especially the young and up and coming investigator. This is part of being as part of IHVN, right? We're gonna have to groom young minds. So please, any questions you have? Is there one in the corner?
Thank you.
Is that a prof? Yes, prof.
My question is to the first speaker. This matter of sex identity, it's a global one, and in fact, I'm surprised that it's gaining so much attention here in Nigeria. I just want to know, how do you come about recognizing them? Because this is a very personal thing, even to the young children. Their parents may not even know. So how do you recognize them? And I'm also concerned about the sort of thing that goes on in schools as to what they tell them, so that they do not encourage and think that it is something that can be done. We are reading all sorts of things about what is happening in the Western world. In Britain, I know for sure, where even parents are being taken to court and even serving prison sentences because they do not agree with what is happening, or the child says he's a boy, and the mother says, no, the father says, no, you're a girl. And this is causing a lot of problems at the moment. I wouldn't like this sort of thing to start happening and schools encourage them. How you find them out?
Very interesting question, Ma. To start with, it's not a case of how do you find them. As a scientist, I'm not meant to find them. I think what is more important is to create people would feel comfortable to express who they are. And we that point. And I HIV out. you know, will not express it as an environment.
So beyond whether they have human right to call themselves what they want, how do they affect research? Thank you.
Okay, so again, if you have the males, you have the females. There's some people who are in between, who want to identify themselves either as transgender women or transgender men. I think again it comes to how we ask the questions, how we frame the questions. It's not enough to just say, are you a male or female? But also give the option for people who may not feel that way, so that, again, if you ask the right questions, then you have the responses to be able to disaggregate your data at the end of the day. Otherwise, what will happen is that you will just disaggregate your data by male and female, leaving out a group of people. And because you don't have the information about those people, you won't have the data to provide the evidence-based decision making and allocation of resources, to cater for those groups of people. So again, I think it comes to asking the right questions. One question that we don't ask well is sex, for example. When was the last time you had sex? But what's the definition of sex? Because the assumption is that we are talking about vaginal sex, but it could well be other types of sex. So maybe that's where to start from. Do you want to add to that?
Yes. Because I also conduct research among adolescents, and of course, part of that research is sexual and reproductive health research. And the way that I think about, for your question about categorization, it depends on whether we are doing the study as a study that involves social aspects of life versus biological or physical. So I male and female, and not gender as in men, women, or girls, boys, as male and female. If it's a biologic-based thing, a sex-based thing versus a gender-based thing. So if I'm looking at a study on access to services, and it includes a significant number of people who are sexual and gender minorities, I will separate it out because I need to see how your sexual orientation or your sexual identity, which are two different things, are affected in terms of access to services. But if I'm looking at something to do with physiology, and even with that, sometimes you might have to actually separate out. Then I think about it more in terms of sex-based, male-female versus, identity or sexuality or
Yeah.
sexual orientation. Yes.
Thank you.
There was something else we were talking about before, which I got off track with that. But some of these are considerations for people who are doing research with adolescents, because that is a time when you express your sexuality or you discover your sexuality, and you realize that there are some people who have not the heterosexual sexuality, and it affects how they navigate adolescent transition, whether it's transition of care or transition into adulthood.
Mhm.
And there are many different issues that come up there. A colleague of mine in OAU, Prof. Morenike Folayan, we wrote a paper looking at Nigerian adolescents and whether or not, to what extent HIV status affects their mental health. And we also looked at to what extent sexual orientation affects their mental health. There weren't enough sexual identity, different sexual identity. There were not enough in that cohort, so we couldn't really analyze by that. But we did have a very interesting paper that showed that those who were HIV positive, as you would imagine, had much more severe scores in terms of their mental health. And those who were sexual and gender minorities also had much more severe scores. And then those who had HIV and were sexual and gender minority, it had a combined sort of syndemic effect there, where they had more issues. So when you are thinking about doing mental health services, you have to think about it that way. And for me as a physician, I think of it as, who do I need to provide healthcare to? What do they need from me, and how can I provide it? So
I think we may have time for maybe one. I know the time is running short. This is a very interesting topic, but one more questions, if any. Okay. So I see 3 hands here from this side, maybe 1 on that side. So we'll start from that side. 1 question there, and then we'll take 3 here. Those will be the last set of questions. And if you have any more, we can, please feel free to approach both panelists.
Yeah, my question is to Dr. Adebayo. You just said that we have with estimate of the key populations in Nigeria. And since 2013, we have several estimates. Then my question is, what was those estimates? Is it that the methodology was wrong, or it was the implementation of those methodologies that was wrong? So what really is wrong with those estimates that we had in the Nigeria past? Thank you.
Thank you. So maybe then there was questions here, right? Hands here.
Actually, it's to the first speaker. Actually, I've come to realize that in the name of making a conducive or comfortable environment, there's a thin line between comfortable and encouraging, from my experience. Although part of the responses that you gave, and Dr. Nadia had actually answered part of it, I asked the right questions, then categorizing the study. I just wanted to know, what other things can we do to ensure that, yes, we are still staying in, creating a comfortable, conducive environment and not encouraging? I'm asking this question because there was a time I was in this kind of a gender class, and we found out that the tutor of that class was actually encouraging and not trying to make us neutral. So that's the reason.
Thank you. So maybe IB, if you have a quick one.
Okay, very quick one.
I think that's it.
Thank you very much. My question is also related to this, and I'm looking at what ways as a country will we be able to navigate the moral hazard about the KP program? I was in a dissemination program some weeks ago, and the figure that were being presented about the number of transgender in Katsina State particularly raised a lot of flags. And the question is, if we have this amount of transgender in Katsina, where are they? And a specific question is, are there programs that are financial based or JAPA based kind of support that people just want to key into that program just for them to have opportunities of whether financial or emigrating out of the country that is making people rich. So how do we as scientists, will we be able to really differentiate people that are truly having this attitude or behavior from those people who just want to benefit economically or otherwise?
Thanks, IB. I think that's it, right? Okay. Dr. Ibate has one quick one, please.
So, Dr. Nadia, in terms of children, what is for you the most critical challenge? Because it's an area I'm interested in. I don't know if it's a consenting process, getting the mothers involved, issue of attrition, but to get a perspective, what really is the biggest challenge for you?
Thank you. So quick responses, maybe 2 minutes each, if that would be good. Thank you.
With research in children, and I'll talk about the foundation of research in children, that's their participation, is consent and defining different ways, different types of consent. And when you are conducting research among children living with HIV, you're dealing with a lot of children who are orphans. In some studies, up to 30% of them are orphans, whether orphan one parent or orphan both parents. And so you come into the issue of who is the primary guardian or the supposed legal guardian for this child, who is going to have them participate in research. And so often when it's not a biological parent, it becomes a problem because these are people, including biological parents, who really don't want HIV to be talked about as much. There's a lot of stigma. And in some families, it's the child with HIV who flags that this family has HIV, because adults can live with HIV for a long period of time. But once there's a child involved and the child gets sick, and gets sick seriously, that the child is the one who waves that flag. So in research, it becomes a problem with consent, whether it's a biological parent, but it becomes worse when it is a non-biological parent, because they really want nothing, very little to do with HIV, and already having challenges taking care of the child. And now you want them enrolled in a study, which brings in more complications. So one of the things I would like to see is IRBs, that's Institutional Review Board, starting with NREC. They have some information on assent for children from 12 to 18. I have that document saved in like 5 different places in my laptop because it's very helpful for me. But there needs to be more. And there's a concept called legally authorized representative, LARs, where you can have someone to stand in for the child. It doesn't have to be a parent, but at least legally based, so that when you need to find someone to assent, to give permission or to give consent, that person also has an understanding of research and can have that happen. Otherwise, a lot of times you have children not being able to participate in research, including adolescents too who are minors. So LARs and emancipation of minors, and how Nigeria would define that to be, get a consensus on that. Thank you.
Thank you. That was a good response regarding the IRB. So, Dr. Sylvia.
Okay, thank you very much for all the questions. With regards to the size of the size of the population, yes, I do agree. Yes, that we've had a few size estimations, but you also know that these were done in some states, not across all of Nigeria, and we've used different methodologies. There's a need for us to triangulate and come up with sizes that would apply across board. But right now, what we're doing is that we're just, using the information that we have, and then the methodology that is the best. May be difficult, but at least let's have the triangulation. I think the government is working towards that. Triangulate and then have better estimations. How do you create an enabling environment? Encouraging sexual. The way that sounds, even that question, I think is a bit biased because when we talk about what you're not, I feel that it's not something you can pretend to be. You can only be yourself. And I think what is important, and I believe right, and that's what we should all strive for, is to ensure that everybody is comfortable. No matter what you do, whether the environment or not, people will remain who they want to be. It's either they feel comfortable and come out office, or they're on the ground and they remain on the ground. People remain on the ground despite the homosexuality, the homophobia, all that. Anyone want to do that? So that's the question we should ask ourselves. That in an environment that is, yet they still do what they want to do, but they're on the ground. Why don't you encourage them?
It is, at the end of the day, I think it's for healthcare, right?
Yes.
If we all are a missionary to provide equitable access, we do have to approach this topic and approach it frankly and transparently of how to engage everyone into healthcare. And so I think the time is up. I think we knew this was going to be a provocative session. And I would like to thank the two panelists for stimulating the discussion. And thank you, the organizer, for putting this on the agenda. Thank you.
Thank you very much for a stimulating first roundtable. I think this, that's what research encourages us to do, to have these very tough discussions and to make sure that individuals are also informed. And I think the issue of balance, it's a very important one, because just as you want an individual to feel comfortable, you also want to make sure the rest of the group are comfortable, not shoving or discriminating. So that's a good start. Thank you so much for that wonderful panel. I know that is a discussion that we're going to continue over time. Now, the next chair is Dr. James Ayameta. Discussions we've had today, there's been a lot of interest in terms of engaging the private organization and our partners in industry. And so I hope that us to talk about that a little bit. And apologize for time is taken, but I think that these are really important relations to have. So we'll have this round table, and then we'll have a very exciting investigators. Over to you, Dr. Ayameta.
Thank you very much, Prof. Good afternoon, everyone. One of the things that has been very obvious throughout today is that IHVN has been able to do a lot of things. And it's important to note that this is possible because of a lot of collaboration. And we are very privileged to have industrial partners with whom we have engaged and been able to deliver on a number of projects, and even to begin to think of what we can do going forward together. So we are very excited to have some of them here in our midst. So what we'd like to do now is to invite some of our industrial partners who are here to the stage. I want to start by inviting Dr. Felix Ofungwe, who who is the CEO of IHVN Medicals, to the stage. Also, Dr. Busari Olusegun, who is a representative of Roche, to the stage, please. And then we have Miss Happiness Iguatu, who assistant manager with Kache, please, to the stage. Okay. We also have in our midst a representative of Nkaba Biotech West Africa, Mr. Olutunde Badmos. Okay, so the rest of them, we would encourage you to move over to the next stage because we still have a representative from Meslo Mokesh, who is here. Okay. Also, we have online representative of Illumina, Rodolphe Vecchino, who will join us, but he's online. So the general idea for this session is to kind of simulate audience discussion. What we do is to allow the panelists introduce themselves. We'll give them some time to talk about the topic, the major 3 points that we have here. And then afterwards, we will ask some questions. Now, the points that we're looking at this afternoon has to do with their experiences and the challenges that they have encountered in collaborating with research institutes to improve diagnostic and research in Africa. And of course, in this context, we're thinking about Nigeria. It'll be nice to hear how they have approached or addressed these challenges and what future collaborations that they think can be engaged in to evaluate or validate diagnostic products that could come through this sort of partnership. So we welcome you and we thank you very much for being here. So perhaps we may want to start with Dr. Felix, and you may now speak to the topic under discussion. What do you have considered to be your experience and challenges in terms of collaborating with research institutes in Africa and precisely in Nigeria, how you've dealt with such challenges? And what do you see to be future opportunities for, for collaboration, especially in the area of diagnostics, looking at new products, new pipelines, and so on and so forth? Thank you.
All right, thanks so much, Dr. James. First of all, let me make a correction. Maybe this is the fastest doctorate ever earned. I'm actually not a doctor. I thought maybe by walking off the stage, I immediately became a doctor, but I'm not a doctor. But anyway, it's good to be here. My name is Felix Ofungu. I am the Chief Executive Officer of IHVN Products Nigeria Limited, or IHVN Medical as we're known. We are distributors for a number of companies, including Roche Diagnostics, as well as Illumina in Nigeria and in 16 other countries across West and Central Africa. And I'm very excited to be here. We've been working with IHVN for quite a few years now, and congratulations to IHVN and the team here on this beautiful complex that we're in. In terms of the question around the experience, a few years ago, this was before the pandemic, so this was in 2019, or maybe a little bit earlier than that, I think 2018, I had the opportunity to meet Professor Ashley, and based on the force of her personality, shall we say, I was encouraged to support some of the research going on in the International Research Center of Excellence. But quite frankly, I was truly blown away by her vision for doing more, especially applied research in these parts. And I came out of that meeting. I was not the CEO of ISN at the time. I had to go convince the person who was that it made sense for us to devote a good portion of our profits every year to research and development, and that not only that, but I had found the right vehicle to pilot that with, which was IRCE and IHVN. It was not an easy exercise to convince not just him, but other members of the team. I remember when I first laid this out at the town hall meeting, there was a collective sigh at the prospect of devoting 5% of our profits, which was the proposal I made, to research and development, and not just giving it to staff as bonuses. So to address part of your question, which is, what was the experience like? This idea that R&D is important and we should not just wait for it to be funded from outside is an evolving, I think, proposition. It's one that, frankly, then in 2018, 2019, there was, at least from my perspective, a lack of appreciation for the need for that. And I'm hoping that improves. But we were able to get that passed, and we were able to support IRC and IHVN on a study around the intersection of NCDs and particularly diabetes and within an HIV cohort. And some of the early responses and reports out of that study were quite interesting to review. Unfortunately, COVID got in the way, and I don't think there's anything we could have done to prepare for that and ensure that the study kept up. But I think in hindsight, perhaps communication, over-communication perhaps on both sides would probably have helped, because I had to report back to the board as to what was going on, and of course, continue to work with IHVN. So just, really ensuring that communication was continuous, frequent during that time, particularly during the pandemic, I think would have helped tremendously in terms of the challenges that we faced. So I'll pause now.
Yeah, okay, thank you. So we can go to Busari, please.
Thank you so much. My name is Busari Olusegun. I work with Roche as the business development lead for West Africa. But before that, I was with the PERFOR program, and I've worked on certain research out as well. One of the key things that we say in Roche is we do what now, what the patient needs next. We do now what the patient needs next. And we believe a lot in R&D, to the extent that 30% of our profit every year is rolled back into R&D. But the major question that we should be asking ourselves is, how many of these funds get into Africa? It's there, it's open, but we're looking for people. We're looking for people to collaborate with in a lot of ways. And some of them, one of the key things that we have also started in Africa these days is we are quite interested in the African Genomic Project, wherein we are much more focused around how do we do drugs, how do we do pharmaceuticals, how do we do diagnostics that is tailored to Africans itself. And this has really helped a lot, especially in the cancer program itself. And in a lot of ways also, there are so many other investigator-led initiated studies that we are doing in Africa, but how many of it are we able to carry out? Unless you come on the table, unless we co-create, unless we are able to work together and we are able to plug into it, how do we get the benefit of this? What are the challenges with the ones that we both here in Nigeria, in Ghana, and in a lot of other places in Africa? One of the key challenges that we have had in a lot of the cases is we believe a lot around co-creation. In co-creation means we should put all the money on the table. It should be where we can support you and bring up the idea, how can we support this? Part that we are going to be able to put on that. Secondly, is why there should be, and we would, I think that is one of the ways in order to be able to improve that process, a platform, a collaborative platform where the goal of the industries, the interest of the industries can be shared, and then the researchers can always align on the basis of looking at. About a year ago, we got a team to visit IRCE, and the very first question everybody was saying was, so do we have a place like this in Nigeria? Yes, that can do this kind of a level of research and all that. Because most of the research that we want to do, the next thing is, okay, can we go to South Africa? Can we go to Kenya? But these things exist in Nigeria. And this is something that the team members are always interested in. Another one that I would also like to talk about is the issue around data integrity. And because we work a lot in a highly regulated environment, compliance is always an issue, even in your research that you do, especially when you are talking about bringing a product to the market or within the pipeline and all that kind of a thing. The non-disclosure agreement that needs to be in place, and we should be sure of the fact that our own interest is covered from your own side. And that is a very critical issue that we always look at whenever we do this. There was a recent trial we collaborated with some institutions in Nigeria. Interestingly enough, we do not have the equipment that can do that within Nigeria. So what we had to do is, okay, can we get some of these samples and then we ship them back to Switzerland in order to be able to analyze and do most of those things. But interestingly enough, then the sample integrity comes to case. The issue around the data when you want to start analyzing it comes to issue, and those are the challenges that I will stop here.
Yeah, so thank you very much. I think we should engage more because it appears we have some things in place already to address those kind of challenges. I would like to make progress to Ms. Happiness from Kachi.
Thank you very much. System protocol. I definitely am glad. My name is Egwatu Hodes. I work with Kachi Company Limited. Kachi is an indigenous Nigerian company, and we've been in the business of serving science for the past 1989. That's about 34 years. And we've been doing this with some collaborations with organizations like Thermo Fisher, global leaders in manufacturing, equipment, reagents, and all that. We've been in the supply of in this business for this long because we believe in quality. Now, one of the issues I find in research institution is the focus, or no, not focus. Not so many institutions are focused on quality. Not so many. I would say I've not done business with IHVN. I've only done, but not so much. So I can't say categorically I belongs in the park. Yes, because I have not done business with IHVN. That in many university institutions, a whole lot, they are more concerned about what gets back to them. As individuals, as men. So quality is compromised. So I would want to see, this is one major challenge in the research institutions. Now they compromise quality for personal gain. So if this tailors down of research to the quality of reagent, what their integrity compromised when quality is compromised. So there is no way we will, as a nation, as Africans, I want to see us focus, removing our focus from personal to the global good. When this is done, it will improve grants. Because when they are sure, when grantors are sure that what you are presenting makes good sense, evidence-based, they are authentic, then subsequent grants can come to Africa. We can improve on every other thing. So this, my major challenge I see in the research industry is how can we move away as a people, as top management, from personal to global good, because it definitely will improve what is eventually taken back, what we research on, what research. I'll give an example. Personal gain, they will prefer supply Nigeria.
and in Abuja. I'm coming from Lagos, of course, to grace this event. So yeah, when I saw the topic of discussion, I was very excited. Excited why? Because challenges. There's something very interesting. Maybe I should say it like a story. So we approached a particular researcher from a research institute. I would not mention the name. And then we tried to like push, oh, we want to partner with you. We want you to patronize us. We want to work with you for your research. And we reassured them that, okay, we would supply very high quality equipment, reagents, and consumables for your molecular research. And then they complained about, I'm happy a lot of the speakers have spoken about the funding issue we have in, and the story continues. So one of our marketers went to the market, the open market, because we tried to talk with sellers in the open market. And lo and behold, we saw one of the researchers in the open market trying to buy some of the reagents we want to sell to them. Now, I think I've been able to highlight some points in my story. In open market, funding, everyone complains no funding, and thanks to the Naira dollar, makes even buying quality equipment very expensive for many institutes. Now, open market is another big issue because now open market they are just sellers. They are not scientists. They have no idea in terms of the storage, because molecular research is very sensitive in terms of temperature, in terms of the type of storage. You don't just put it in a hot room, but that is what happens in the open market. So meaning a researcher that buys from such, your tests are likely to be, you'll probably have a lot of false positive results. Now that is the issue we're having. So we speak with one now, that's just a story that painted most of our challenges. So you speak with this one and they say, oh, your filtered tips are too expensive to go to open market. Open markets, you don't know how long that filter tip has been in the seller's shop. Maybe the filter tip sale was on clearance sales. Maybe clearance sales because probably it's going to expire August. That seller saw it as, this thing is 9,000 naira. These people want to clear it for me for 3,000. He packs everything, drops it in the shop. He didn't see anybody to buy it for the next 1 year. Then a researcher that finally maybe got a small grant. Small grant, oh, now maybe let's say you have a small grant for HPV. Let's say the small grant is $5,000. You want to keep some for yourself. And you want to also show your sponsors that you carried out this research. Then you go to the open market, you buy it at, the seller now sells it at let's say you have to buy it 9,000, you buy it for like 3,000. And then your tests are not, you don't have controls for QC to check that you are actually getting right positive, or you are getting your negatives are truly negative. So those are the challenges we have in short. Then sorry for how to tackle it. Yeah, we've tried talking to some of them. We've tried also talking to some sellers in open market to also educate them in terms of storage, because we know we cannot push them away. So we can also then what we can do more like a CSR is educating open marketers on how to store, how to and also maybe advising them not to buy so large quantity of reagents and consumables. Rather just buy, and then if they need, they could also come to meet us, and we could have some affordable sales plan for them.
So thank you.
Sorry,
Thank
lastly,
you.
QC.
I probably need to come in here. Thank you. I think that your point is made. We appreciate those silent points, and also to the panelists. Thank you very much for all of the points you brought out. But just before we open up for further conversation, I was wondering, do you have any thoughts around future collaborative opportunities? Perhaps you could just highlight that very briefly, because we're really running behind schedule. Okay, we can start with Mr. Felix, please.
Yeah, what's top of mind for us right now at ISN are topics around precision medicine, specifically the role of next generation sequencing in precision medicine. We're excited about this area, especially with our collaboration, our partnership with Illumina. And there's an area that I'm hoping that we work with IRCE, IHVN on. Also areas around proteogenomics. It's what's top of mind for us at ISN at the moment.
Okay, thank you. I just forgot about our Illumina representative who is online. Please, can you come in here?
Yeah, good afternoon. Can you hear me?
Yes, we can hear you.
Okay, there's a nick on your side. So, yeah, I see, as you mentioned, we are running out of time. I just want to mention one particular topic about the challenges that we face while working with research across Africa, but also in Nigeria. It's about the fact that some of the work that researchers should do is actually sent out of the continent. Many projects, particularly in our area, next generation sequencing with Illumina, are sent to countries in Europe, in UK, even in the US, and I saw some projects even done in Singapore. So what we do at Illumina, and I should mention that we are a global company in sequencing genotyping, present across the globe. I'm managing our distribution network across Africa, on Northwest and Central Africa. So what we do is that we are trying to empower as much people as possible across the continent with our technology. This includes training. It also includes the ability to find the right solution that are tailor-made to the continent, because we obviously have the non-communicable disease like cancer or hereditary disease, but also a lot of infectious diseases across Africa as well. So we try to put in place solutions that allows public health and also research to manage these kind of issues. And obviously, our goal is to be as close as possible from our customers. This is why we have people across Africa now supporting and trying to understand the specific needs that we have across the continent. And all of this, that we are able to bring this technology into research that we need it, and make sure that we keep the job in the continent. Because one of the issues we see, if samples are sent out and all the job is going outside, not only that the know-how and the knowledge is in the continent, but also we are thinking about the future. All of these is actually, and all these data are really the wealth of the future, and this can allow to find the right therapeutics and being able to support better our people across Africa for their health. And the better way to do so is really to keep our population in Africa able to have the higher hands on this data and how it can be managed and used in the future. Yeah, that's just what I wanted to mention about some of the issues we are facing in our technology with research and development with our partners.
Thank you very much, Rodolphe. Just very quickly, any other areas you see for collaboration very shortly? We're really running out of time now.
So, two other things, in addition to what he has talked about, the next generation sequencing, we also were quite interested in. Another thing is in implementation science, where we're looking at centralized testing in support of TB testing, where that is a very great thing that everybody in the world is looking at currently now. And we're also interested in that. Then hepatitis C. We have a new product, HCV Duo, wherein you can detect the antibody and antigen at the same time. We're working with some other researcher in Ghana currently, and we're looking for other persons even across Africa, yeah.
Okay, thank you. Is there something that you have in mind that hasn't been touched by any of the panelists?
Definitely.
Okay,
That's
please,
why
very,
I have the mic
very
before you
briefly.
even called me.
Okay, please, very briefly.
Okay, for Kachi, the next level, not really next level, we are already on it, is supporting Nigerians doing research for Nigerians. So that's to say that we are encouraging researches that deal with us, not just something from grantors and all that, from grantors and all that. Now we have gone ahead to establish a lab here in Nigeria. We have both the analytical and molecular lab. The analytical lab has quite a wide range of equipment, NMR, HPLC, GC, just anything you can think about is in that lab, so that we can do this research. If the Illumina guy mentioned something like that, do our own research right here in Nigeria, and that is the way forward now. We are ready for collaborations. We have the equipment that you can just imagine about. We have them right here in Nigeria.
Thank you for this point. Quickly, please.
So one of the things I wanted to say is that for us, I think about just beyond selling equipment and just selling the reagent, we actually want to train people. We want to train researchers, molecular diagnostics skills. We want to impart it to early career researchers. So if you're looking at working on vaginal infections, any kind of infectious diseases, just name it. I think we're starting that with the IHVN already. So we're open to collaborations with institutions who are ready to, who have the equipment or who don't have the equipment. Just we're open to further discussions.
Okay, thank you. Okay, so would really thank you very much for your time and the thoughts you've shared with us. And we look forward to continuing our conversations with you to identify newer areas to work together and how we can strengthen already existing relationship. I think now, do we have time for any question, Prof? Okay, please, brief questions now from the audience. Okay, please. Okay, so we're going to take all the questions and then they will have time to respond to them.
So good afternoon, everybody. My name is Dr. Talala Teju from part of my question has been addressed by the lady from Kachi, but as I look through this list, I see a conglomerate of multinational companies who have representing Nigeria. Maybe just ISN, but then, I know ISN is leveraging on the distributorship they have with Roche. Where do we find opportunities, just like was mentioned, for engagement with local entities who are either manufacturers or collaborators? And I don't know what industry-specific experience you have to be able to identify these entities and be able to leverage that local capacity. As a Nigerian entrepreneur working in Nigeria, even though I'm in technology, I see that there's a lot more deference to this international organizations just because, there's a lot more credibility and there's a lot more branding associated with it. But I feel there's capacity locally that we can leverage such that this becomes a more seamless interaction while also building that capacity. So just to get your insights on that, thank you very much.
Okay, thank you. Let's go to Professor Salako now, please.
Thank you very much. I'm quite familiar with many of you guys and your company. But what I want to ask is, what is your company doing, or what are your companies doing? I'm taking the questions individually to actually assist Nigerian researchers to take the results of research to market, so that rather than importing and bringing your things to come and sell for us here, how do you plan to assist us here to develop that locally so that your company can also market it
That's the way you can improve our economy, create job for our people, and of course get cheaper product to sell for Nigerians. I think we should begin to look at that, so you don't keep bringing those things from there. And many of them, of course, standard are set by whatever they have seen in their own environment, rather than our own environment. Thank you.
Thank you. Any responses? Okay, one more question, please.
Okay. Good afternoon. My name is Gloria Oku. I work for Project Pink Blue, and I'm also a cancer patient. So I'm going to speak as a cancer patient. And what I'm going to say is a blanket statement. I want to say that I think patients are not being carried along enough. I think there's been some changes, but we're still going to keep harping on it, that if these researches are really patient focused, then patients should be carried along, because we want to know what's happening. We want to know what chances we have. We want to know how we can contribute. In as much as stigma has sidelined a lot of patients and they don't want to come out, I can tell that there are many patients who want to know what's happening, who want to be carried along. So when I hear, oh, we did this program, we did this clinical trial, I always keep wondering, so who are the patients? Because if you ask a lot of patients, they don't know anything about what is happening. So I think we should begin to carry patients along. And like the last speaker said, some of these drugs, please, there's any way they can be manufactured here. The cost of drugs is killing patients. We can't afford drugs anymore. So please, we should be looking at also, having these drugs produced here, so that the cost of buying, the cost of distribution, every other cost is, goes down. It's going to help patients a lot. Thank you very much.
Okay, thank you. Any quick responses? I think we need to.
Okay, a quick one. I'm Professor Patricia La from UniJOS. I supervise a lot of PhD and MSc students doing researches in genomics, a lot of viral, bacterial, and parasitology. And I'm excited about this meeting, meeting this range of companies, and do I call some of you are manufacturers of these reagents that are very expensive, and honestly we have challenges with our students. There's an increase of researchers, people interested in public health researches, but the reagents are quite expensive. I want to know about any trials with respect to local isolates compared with what comes from other geographic regions. If there's anything going on between your facilities and various research platforms. Also, I would want to find out about your offers to support researches, particularly where there are limited resources. Not many do get funding from maybe TED Fund in Nigeria, for example, and maybe NIH funding, but they're trying to do researches that have great prospects for the future. I just want to ask these questions and comment IHVN and the Research Center for this. I benefited from the tutoring of Dr. Blackner and Mann, with this commissioning this. Thank you.
Thank you very much. I don't know. There's so many important questions. I think I'm going to suggest that we discuss further with them, the panelists. And then, of course, if you cannot find them, you can come to us. We can help you find them. Please, first.
Thank you so much. To say, so much to do, so little time. But really what we want to do is begin the interactions, and hopefully we'll continue so that by next year, for we know that half a day is not enough, right? Yeah, exactly. We need 2 days for meaningful interactions, especially for people who have traveled very fast. So we're learning. We are young. But guess what? We left us the best for the last. Now you're going to hear all of those people that Dr. Blattner shared with us earlier on in one of his lessons learned, that they should outshine us. So Matt and I try planning a retirement. No, speak for yourself, he said. Okay. All right. So Avase is rushing over here to start the next one going, but you are actually our first presenter, right? And you're all going to impress us by keeping to time and just making this really stimulating. Thank you all for being so patient. Over to you, Dr. Okpokoro.
I'll please encourage the timekeeper to let me know when it's 5 minutes, so that all to the end, so that I can rush things up a little bit faster. So good afternoon once more. My name is Dr. Okpokoro Evezi, and I'll be talking briefly on the prevalence study, prevalence and risk factor of Mycobacterium tuberculosis infection among healthcare workers in HIV treatment centers in North Central Nigeria. I must say that this was funded by the EDCDP, the European and Developing Countries Clinical Trial Partnership. This study is a baseline study, as I said earlier on, a prevalence study that sits among the parent study, which has the full title, Mycobacterium tuberculosis infection rate among healthcare workers in HIV care and treatment centers in North Central Nigeria. And you can see in bold text our key co-investigators in this study. And you'll see from the objectives, the text in bold refers to the bits that this presentation covers, which is the prevalence study or the baseline study. We had 5 core objectives from the parent study. One is to measure the prevalence, incidence of MTB infection, and as well as identify predictors for such infection among healthcare workers. Secondly, we wanted to find out what was the impact of or exposure of being in an HIV clinic setting with the risk of MTB infection. Other objectives were to measure the level of TB infection control practices at baseline, month 12, among centers, and to see if these TB infection control practices were associated with either a decrease or increase, as the case may be, of MTB infection. And lastly, to put together characterized samples for future exploratory studies looking at TB markers or cytokines. The design of the study was, the parent study was a longitudinal cohort study. However, for the purpose of this presentation, I will focus on the cross-sectional part of the study. It was funded by EDCP, as I mentioned, with 150,000 euros over a 3-year period. I'll skip this, but this just to give deeper understanding on the processes, the clinical process, and the lab processes that were involved in the conduct of this study. I want to jump into the core findings of the study. But by and large, I mentioned 3 different objectives which this prevalence study addressed. One is prevalence, two is risk factors, and three is to see the impact of HIV clinic on MTB transmission or acquisition rather. Now, this study was conducted among healthcare workers, given the fact that healthcare workers seem to have a high risk of high exposure to TB, given that PLHIVs are likely to have TB compared to other patients. But as a background, among the healthcare workers, the mean age was 39.2 years. A majority of them were female, married, and lived in densely populated regions. About 30% to 5% rely on biomass or cooking, and just less than 1% have had organ transplant. These are just key demographic variables that will affect the other results we'll talk about later on. It's good to know that the majority of these healthcare workers were nurses, and that majority of them were from the medical department. Now, going first to the first objective, we looked at what were the prevalence of MTB infection among healthcare workers. We found that 45% thereabout of healthcare workers within the HIV care and treatment centers or clinics were positive for IGRA release assay. So about 1 in 2 healthcare workers will test positive for MTB infection using the IGRA positivity as a surrogate. Well, in terms of the second question, is there a relationship between HIV clinic and MTB acquisitions, MTB infection acquisition? Well, from our study, we found that the prevalence of MTB infection among HIV clinic was about 44% and 45% in non-HIV clinics. So a 1% difference obviously shouldn't be significant. And we found no significant difference in that respect. However, we do know that in terms of the duration by which people have stayed in the HIV clinic, we found a difference between people who have stayed 4 years and above compared to those who have stayed 3 years and below. So not only is exposure important in having MTB infection in HIV clinics, the duration for which you are probably in that clinic has a role to play in the likelihood of having MTB infection. Well, across the different departments, we found that majority of those of MTB infection was among healthcare workers in the administrative department, which forms the non-clinical healthcare workers or health workers within the within the centers. The list we have with those, I may be asking Nadia why we have this, who have MTB infection, since she deals with pediatric population as well. Now, going straight to define what were the predictors or risk factors that were associated with infection, the non-occupational factors and occupational factors. In bold, we see those that were associated with MTB infection. At the top of it, we see those factors that reduce the odds of acquisition of MTB. If you lived in less densely populated, moderately densely populated neighborhood or sparsely densely populated neighborhood, your risk of MTB infection is lower, or you have a reduced risk of infection. Whereas, if you were increasing in age, and if you were using biomass for cooking, or you have an increasing household size, or for no reason, well, to my own understanding, you had high blood pressure at the point for which we saw you, your risk or odds, so to speak, of MTB infection increased, and this was significantly associated with MTB infection. We do not know why high blood pressure was associated, but that was our finding, and that gives room for additional investigations. Now, looking at occupational factors, we found that non-clinical, being a clinical healthcare worker reduce your odds of MTB acquisition. That means that more people who are not nurses, not physicians, probably administrative staff or security guards and others are likely to have MTB infection compared to those who are clinical staff. However, with increase in employment of years, there was an increase associated with your risk of MTB infection. When we combine all of this together, we found that increasing your being within the age of 20 to 30 years compared to 40 years decrease your odds of MTB infection. And being a clinical staff also reduces your odds of infection. Whereas having high blood pressure and an increasing years of being a healthcare worker will consistently associated with your risk of having MTB infection. So what are our implications? I'll try to go this quickly as I can. That M tuberculosis in Nigeria is high, one, and this has implication for TB infection control practices. One, we think there's a need to target training or TBIC sensitization on non-clinical healthcare workers and not just the clinical healthcare workers as the case may have been. And also the need to strengthen, not just in HIV clinic, but in non-HIV clinics, TBIC practices. In terms of TB preventive therapy, we think that we've gotten some data that could help or strengthen the need to implement latent TB, LTBI programmatic guidelines, as well as the need for targeted screening for healthcare workers who would have spent longer years in service. Well, we also found there's no effect of HIV clinic on acquisition of MTB infection, which is one of the points we want to have. And that means that there is probably better treatment for PLHIV, which is why we have less opportunistic infections such as TB and lesser risk for MTB acquisition. And also the need to Okay, and lastly, we want to stress the fact that there is a need for future TB vaccine trials. We've been able to develop a clear characterized cohort that should spearhead or push us towards being part and parcel of TB vaccine trials, which will help recruitment strategy or other aspect of such a trial, and identify questions for future research as well. Please feel free to go to this web link for this has just been published, and so you can find more from the link there. And please visit the posters 010 and 011 for more information. Thank you.
Thank you. Please sit down. Thank you, Dr. Okpokoro. Now you can take a deep breath. And I hope that I don't see Rebu. I thought he would be going to be right here so that he saves his 30 seconds, right? And if you could put the next presentation, please. We're going to have 4 of them present, and then we're going to have some interactions, a very brief one, and then we're going to get the last 4 back up as well. Good luck.
Thank you. My name is Nakele Robo, and thank you for having me. So I'm going to be presenting the depth study, which is the dolutegravir darunavir evaluation in adults failing therapy, primarily funded by Unit 8, NIH, and the rest of the team there. Okay, so I'm going to try to simplify my presentation because of the diverse audience, but anybody who knows about HIV treatment, which is what we are here for, and other studies that we have done, knows that, as patients progress, or maybe patients fail first line, that it becomes more difficult for them because of the limited options for treatment for those who may require second line. And, the standard of care which we use have more, so to say, adverse reactions, or such as the use of protease inhibitors. So this was what conceptualized this study. That how can we come up with an innovative treatment that will serve many patients who have failed first line in terms of their clinical outcome and in terms of their quality of life? Because it's one thing for somebody to have a virologically suppressed, is another thing for a patient to be happy with his treatment, to be adherent to his or her treatment. So that was how we came about the depth study. So this is actually dolutegravir darunavir evaluation in adults failing therapy. And the global PI is Professor Gail Matthews. I led the study in Nigeria, and we had investigators from UATH at National Hospital. And the study objective was to compare the viral efficacy of the drug regimen, in ability to achieve viral suppression. That's the level of HIV in the blood, to bringing it to a minimum of less than 50 copies per mil in 48 weeks. So it was a 3-arm randomized trial, meaning we had 3 arms of the study, arm 1, arm 2, and arm 3, and we randomly placed patients on these 3 arms. And so because of time, I'm just going to quickly run through what the study was all about. So the first arm was the standard of care arm, which was what we practice, which is actually a PI and what we call it a nucleoside reverse transcriptase inhibitor. I'm not going to go into the details, but that was the first arm, which was what was practiced at the clinics. And the second arm was actually the innovative regimen, which was dolutegravir darunavir. So we are used to seeing the 3-arm treatment, but this was actually a 2-arm treatment comprising darunavir and dolutegravir. And then the third arm was an arm we call the TLD. In our HIV program, we're very familiar with the TLD. So this study, the amount of money that accrued to the Nigerian site, not the global funding, was about 300,000. Implemented it over 5 years. We're much impacted by COVID-19. Nigeria contributed 109 patients to a total of 830 global patients. And these are the study team members, a fantastic team of people, myself, and that's the global PI. So getting to the study findings, we found out that this innovative treatment, which comprised just 2 drugs, dolutegravir and darunavir, versus the TLD, which had 3 drugs, and the standard of care, which had 3 drugs as well, did better than the standard of care. So if you look at this histogram and you look at the histogram on the left, you'll find out that the somewhat yellow is the innovative regimen, and about 84% of the patients achieved viral suppression after taking the drugs after 48 weeks, as compared to the standard of care, which was 71%, and the TLD, which was 78%. And if you look at the scatter plot, you also see that same trend with more granular details, showing that this drug, darunavir dolutegravir, did better. And the fantastic thing about this drug is it's 2-arm. It's a 2-drug regimen. It had less side effects, or less what we call adverse drug reactions. Less pills, the better. So it has less pills as well, and that it has a potential for co-formulation. And patients were very happy because we also assessed the quality of life questionnaire, as well as the anxiety, depression. So we found out that patients who had this drug were much happier with the drug because they complained less of issues associated with the other drugs, particularly the standard of care. This study was presented at IIS and CROI, and it's generated a lot of interest. This is straight out of the ports. This paper has been planned for publication, so you're going to be having more news about this paper. The WHO is very interested, and I believe we're going to see it inform guidelines or policies for managing patients who fail first-line therapy. Thank you.
Awesome. Oh. Thank you. Thanks very much. That is great. I need whoever is changing the slides to the next one. We're going to hold off on the videos. Can you please someone help me here? We're going to hold up on the videos to the next. Let's have the in-person presentation and have a discussion, and then we'll play the videos. So if we can pull up Rita's presentation, and she will be ready to start that. She would be number 5. That's correct. Okay, let's see if you can beat Dr. Erebo.
Okay. All right, so good afternoon, everyone. My name is Rita Okunfo. I work with IHVN, precisely at the International Research Center. I'm a research scientist at IRCE, and then also the project director for the 5 years Global Health Security Coag with CDC. So I'll be presenting on the acute febrile illness sentinel surveillance here in Nigeria. So this is one of several improvement science projects implemented with funding from CDC in response to the COVID-19 pandemic to better understand pandemic and support NCDC better to respond to future epidemics. So this project is under the principal leadership of Professor Bimikul and Dr. Ifedayo, NCDC. Primarily, the objective of this study is to determine the etiologies of acute febrile illness among children and adolescents, as well as adults in selected health facilities in Nigeria, basically to determine the frequencies of co-infections of acute febrile pathogens. In terms of the study design, it's an active prospective case-based hospital based surveillance with laboratory confirmation for each case. So we have 9 priority diseases of public health importance selected in collaboration with NCDC, and these include COVID-19, we have chikungunya, we have Lassa fever, we have yellow fever, Zika, Mpox, dengue fever, West Nile fever, and malaria. Laboratory testing, there are 2 arms. We have the rapid diagnostic testing, there are the Sentinel sites, as well as the PCR testing at the National Reference Lab in Abuja. In terms of the study population, for this study, we are recruiting patients greater than 2 years with acute fever greater than 37.5 degrees centigrade within the last 10 days with no identified source. Again, like I said, the funding is from US CDC, a total funding of $2.2 million. Administratively, this project is about 3 years, but in terms of technical implementation from date of start is about 15 months. So we had a long tour through the administrative process to get started and establish the Sentinel surveillance. This has been implemented in 6 states across the geopolitical zones, and we have them listed there. We have FCT, the capital, we have Enugu, we have Kaduna, Edo, Lagos, and Bauchi. Like I mentioned, this is research in progress. So in terms of significant activities that have been implemented thus far, we've been able to activate the Sentinel site enrollment last year in April. So all 6 Sentinel sites, like I mentioned, selected from the geopolitical zone in collaboration with NCDC and the State Ministry of Health, have been trained and activated for the surveillance. The laboratory testing have also been established. This took a very long toll through trying to establish the most cost-effective diagnostic platform for all of this pathogen. So we have 2 laboratory testing. Basically, we have the antigen-based rapid diagnostic testing for malaria and SARS-CoV-2, and then we have the PCR technique at the National Reference Lab with technical support from IPD, Institute Pasteur Dakar, for the other 8 pathogens. So in terms of sample types, we are collecting whole blood, plasma, and serum. We are collecting both nasopharyngeal and oropharyngeal swabs and VTM, as well as swabs, dry swabs. For the data management piece, that's another very big piece that took through long administrative process to get established. For sustainability and ownership, we leverage the existing surveillance outbreak management system available at NCDC, where we developed an expanded case investigation form that collects comprehensive epidemiological, clinical, and demographic variables for all enrollees, and all of these have been developed and integrated into the existing SOMAS platform at NCDC. All of these have been well established and data collection ongoing. And then also we have the specimen biobanking, so participants consent to biobanking for future tests. And temporarily we are storing the samples at the biorepository here at IHVN, but for the future we'll be moving all of these samples to the off-campus of NRL in Lagos. Laboratory testing is ongoing, and then as well as quality improvement activities and confirmatory tests for the positive PCR pathogens. So these are preliminary findings. So still testing, like I mentioned, testing is ongoing. So in total, we've enrolled a total of 9,562, which is 94% of our set targets. So we're well on target. We've enrolled twice as much adults as children. So in terms of the gender, we've enrolled slightly more females than male. So the next result I'll be presenting are the preliminary results we are getting in terms of positivity of the various pathogens. So for the point of care testing, where I mentioned that we're leveraging antigen-based rapid diagnostic test kits at the Sentinel sites. For the malaria testing of the total sample tested, the 9,562, we are seeing a positivity rate for malaria at 18%. We're getting the highest in Enugu for 29% and the least in Lagos for 4%. For the SARS-CoV-2 RODT, we're seeing a positivity rate of 2.3%. The highest also here, we're seeing Edo, and the least Enugu. So the next slide shows the PCR testing happening at NRL. For mpox, a total number of 50 samples have been tested. So for mpox, we only test patients who present with skin lesions. So of the total sample tested, 50 were seeing a positivity rate of 40%, the highest being in Edo State and the least being in FCT. And then in terms of the gender, we're seeing more positives among the male for mpox than female. And then also we have more positive for the adults. The positivity rate in adults is about 51%. For the dengue virus, of the total number of 66,219 samples tested so far, we're seeing a positivity rate of 1.6, the highest in Enugu, which is slightly above the average, 2.2%, and then the least rate in Lagos, 0.5%. In terms of the age group, we have more positivity rate amongst the children, so we're keeping an eye on the pediatric population compared to the adults, where we had a positivity rate of 1.5. In terms of gender for dengue virus, across both gender, male and female, we have average positivity rate of 1.6. So for chikungunya, we're seeing an average positivity rate of 0.2, highest being in Kaduna, no case yet for FCT and Edo. In terms of the age group, adults, positivity rate in children was quite high at 0.2. For Zika virus, the average positivity rate of 0.6, the highest in Kaduna. And then in terms of the age population, we're seeing that we have more positives in the adult and pediatrics. And then also for gender, approximately 0.6 positivity rate. For West Nile virus, the average positivity rate is 0.8. The highest positivity rate we are finding in Kaduna. And then also for the age population, the adult population had a higher positivity rate of 0.8. And then for the gender also, we had the female 0.8. For the Lassa fever testing, Lassa fever and yellow fever dualplex testing just only commenced last month. So we've only tested 553 samples. We're seeing a positivity rate for Lassa fever for 0.2%. No positive case yet for yellow fever. In terms of key next step is to complete enrollment as well as complete laboratory testing and confirmatory testing for all of the pathogens. So this project is really detecting variable etiology in AFL in Nigeria, and then highlights the importance for differential diagnosis. Overall, this project will provide a framework for routine surveillance at NCDC and to better understand the proportionate causes of febrile pathogens and better plan for pandemics. Thank you, and over. I did well.
Oh, you tried very hard to ignore me. And you did for 2 minutes. But you'll pay for it. Okay, so I guess Edo is standing right here, ready to go, I believe. And his slides are coming up.
I was actually hoping I was going to come last so that I can gain some time. Standing on the existing protocols, my name is Edom, and I'll be presenting our study titled The Knowledge, Attitude, and Practices of COVID-19 and Seroprevalence Survey Among Laboratory and Other Healthcare Workers in Nigeria. The principal investigators for this study, Dr. Ifeda Identified, the DG NCDC, and Professor Alashila Bimiko. Our study objectives include to evaluate the knowledge, attitudes, and practices of COVID-19 among medical laboratory scientists and other healthcare workers in Nigeria. Number 2, estimate the seroprevalence of SARS-CoV-2 infection among healthcare workers in selected states in Nigeria and assess the level of exposure to SARS-CoV-2. Just before I go on, I would like to say here I'll be presenting the findings from only the knowledge, attitude, and practice aspect of the study. The study design was a cross-sectional survey among healthcare workers using the stratified cluster sampling strategy. The overall sample size was equally allotted to the 3 states, and facilities were allocated sample quotas based on probability proportional to size, and the participants
could either consent to either the cap or the seroprevalence or consent for both studies. It was funded by the US CDC, and we carried it out in 7 tertiary facilities in Rivers, Plateau, and Oyo states. This slide will be showing the participant demographics. The total participants we have for the study was 1,341, with the nurses being the highest proportion, greater than 15 years of practice, 31 to 40 years, and the female gender were the highest proportions in those different categories. This slide is showing the scores, the satisfactory scores for knowledge, attitude, and practice of COVID-19 by cadre of healthcare workers using the cutoff point of 80% of the total score. And as you can see, we found the highest satisfactory knowledge among the nurses, with the laboratorians having the least satisfactory knowledge score on the knowledge, attitude, and practice. Doctors had a higher satisfactory score on attitude and practice of COVID-19 infection prevention and control measures. We explored the relationship between the knowledge, attitude, and practice of COVID-19, and following the outcome of correlation analysis, there exists a positive but weak relationship between knowledge and attitude, and also knowledge and practice. A similar but positive weak relationship was also observed between attitude and practice. The linear regression effect of the means was further revealed that for each unit increase in knowledge, there is a corresponding 0.2 unit change in attitude and 0.1 unit change in practice. Linear regression effect also shows that a unit increase in attitude brings about a corresponding 0.1 unit change in practice. Bivariate analysis was initially done at 20% significance, and the significant factors that we found was further explored in the multivariable analysis. And factors associated with the knowledge, attitude, and practice of COVID-19 among healthcare workers, we found that healthcare workers' age, years of experience, cadre, marital status were all associated with COVID-19 knowledge. The lab scientists and doctors are 1.5 times less likely to have satisfactory knowledge than the nurses. Odds of good knowledge is almost 3 times more likely among healthcare workers with 6 to 10 and greater than 15 years of experience as compared to those that are less than 2 years of experience. Factors that affected attitude included the healthcare workers' cadre, state of residence, gender, age, and marital status. And we found that the odds of satisfactory attitude towards COVID-19 are lower in lab scientists compared to the nurses. We also found that male healthcare workers have a 42% chance of demonstrating satisfactory attitude than the females. The factors that were significant with the practice of COVID-19 include gender, years of practice, marital status. And the odds of satisfactory COVID-19 practice is 2.5 times lower among lab scientists compared to the nurses. Odds of satisfactory knowledge, odds of satisfactory of COVID-19 practice, increased by about 40% among healthcare workers with satisfactory attitude to COVID-19. This slide shows the specific responses to questionnaire items that we used. We found that with regards to knowledge, the least correctly answered questions were questions regarding the source of COVID-19 infection, knowledge on the appropriate use of PPE, also COVID-19 vaccine providing protection for everyone, and medical treatment for COVID-19. We found that over 40% of healthcare workers responded wrongly. 64% of respondents had a negative attitude, and that the Black race is protected towards COVID-19. Although 69% reported often worrying about being down with COVID-19, over 90% of healthcare workers responded being confident to care for the sick COVID-19 patient. With regards to practice, majority reported unacceptable practices. 85% of healthcare workers reported not maintaining social distance, and we found only 21% and 7% respectively, reporting regular use of nose mask when in contact with people and regular hand hygiene practices before and after touching a patient. Yeah, the implications of our study, our findings highlight the challenges faced by healthcare workers during the COVID-19 pandemic and the need to increase training program regarding not just COVID-19, but the epidemic-prone diseases. Borrowing the word of the DG NCDC, which you said earlier, COVIDization. Despite the extreme or the thought COVIDization, we still found that there were huge gaps with regards to knowledge, attitude, and practice. And our study was conducted during the 6th wave of the pandemic. And that makes us to see that there's a requirement for significant improvement in the areas of practice, most especially. It also highlights the need for training programs to include sessions on disease etiology and public health prevention and control strategies, like PPE and vaccination across the various cadres, particularly laboratorians. As you can see, that there was ones that score lowest on the three. With further training and improved competency of healthcare workers, anxiety likely will be alleviated and patient health outcome improved. Although the COVID-19 pandemic may be over, additional exploration is needed to understand challenges with implementing safety protocols to better handle health emergencies. And this is just to acknowledge our partners that worked together with us. And also, just before I conclude my own statement, my presentation, I would like to express my deep appreciation to the IHVN management, Dr. Patrick and Dakum, for giving us a system that will make us to grow. And also to Prof. Thank you very much, man, for the opportunity.
Now, please note Dr. Patrick and Dakum for his promotion. So the final speed presentation is going to be by Dr. Oyemeta. After that, we're going to open the floor up, have a little discussion, and then the next 4 presentations will all be on video. So they will not be running over time. Thank you.
This talk is SARS-CoV-2 immune response dynamics of vaccine in African population. Let me start by saying that this is a project that have some of the results that similar talks that have come before. It's a collaborative project between ISA and the University in Cambridge. We have Professor Ravi, and in IHVN here we have Professor Lashley Abimik, and of course the list of co-investigators is there. Just to set the stage, you may be wondering why the relevance. Well, after COVID happened, it became obvious that there was paucity of information from certain populations, especially the HIV population within Africa. The issues around the response to vaccines, were effective, and for how long, and so on and so forth, were not addressed. So part of what this project is aimed at doing is to get additional information that provides further insight. Well, so the objective is to characterize humoral and cellular responses to SARS-CoV-2 vaccine in an urban general population of people living with HIV in Nigeria, as well as matched controls. In terms of the study design, it's a longitudinal cohort study that has a descriptive and observational component. So we're looking at general population that is that serves as control, and of course PL-HIV, which is a really area of interest. It's funded through some pool funding coming from Wellcome Trust, African Research Excellence Fund, Cambridge, and Cambridge Africa Program, The total funding for this project is roughly $100,000 US, and it's going to run for 3 years. Visited sites in January and began to collect samples in connection with this project in late January. So at the moment, we're working with 2 clinical sites, at Socorro District Hospital, and then, of course, Lugbe Primary Health Care Center. The number of baseline is 332, and we're collecting different samples because of the nature of the downstream analysis that needs to happen. So we are collecting whole blood and processing this into plasma, nuclear cells, was collecting nasal swabs, collecting stool samples. And so far, at this point, we have collected samples from 1,000 participants, patients or participants, and this is both at the baseline and then through follow-up time points. That is study team there. So just to give you an idea, actually the schema of how the study has been designed. So we have a pilot coming at baseline. We collect all of the samples that I mentioned in the previous slide, and then they get vaccinated. And then we collect samples again at the different time points that are here. Again, 2 months post that baseline, they get a second vaccine. And then we collect samples. The initial stage of the project is designed to last for 18 months, but there's potential to expand this. Now, what you have there in green just basically shows that we have finished that. In orange, still ongoing. And then we have the 6-month post-booster, as well as 12-month post-booster, which will still happen. Again, the sample types that we're collecting is shown there. One of the things that we've also tried to do is to go back to the patient folder to try and extract information from patient folder. And so if you look at the very lowest row, you will see the for count. And so this is basically coming from the folders of the participants. The lowest CD4 count that they have actually had before you had the immune reconstitution happening. And so that's just the baseline of the study participants. So in terms of other things that we tried to do within the study, we also had a vaccine hesitancy survey that was administered to all of those that agreed to be part of the study. And right now we've collected all of that data, and we are in the process of analyzing that data to see how the participants are trying to complete follow-up visits 1 to 3, and then of course the follow-up visit 4, which will start in September. And because this is some of the work is being done here, additional analysis is happening. It's a partnership, because what we're trying to do in the study through this to build the capacity we have here within IHVN. For example, the initial immune response work would happen in Cambridge, but then there's an understanding, an agreement that we will then do the later ones here, just improve the capacity that we have to conduct similar studies going forward. And this is just to acknowledge all of the participants in the study, and these are the funders who have supported the study. Thank you.
Can you switch with the lady here? I'd like some balance, please. Can you move that? Thank you very much. We're not supposed to be at the corner, right, Mrs. Blattner? Very interesting. I'm not sure who should get the prize. Is it Dr. Irebu or is it Dr. Oyemeta? And Dr. Irebu, oh yeah, okay. You know we have the videos, right? You're going to control it from there. Okay, so that's great. We'll open the discussion to the floor and have a few questions, and then we'll have the videos play, and then you have all that time to go and get ready for the gala night. I see one hand here. I am looking, yeah, and I see another. Oh, are you telling me the time is up? Okay. So let's start with the two, please. Young ladies, so yeah, please go ahead.
Good afternoon, everyone. Violet Water from the Oram Institute in Johannesburg, South Africa. It is a great pleasure to be here and listening to the fantastic talks. I limit it to 2 questions and then I can discuss afterwards.
Thank you.
A question to, and I won't get the names right, the gentleman who presented on the two-drug regimen for HIV. Just to clarify, so how long did you follow up the patients, and was viral suppression maintained during that follow-up period? Just to clarify that. And the second question to Dr. Okoro, so around the healthcare work you've done, so you clearly showed, I think the prevalence of TB infection was 44%, if I recall well. So a question to you, I think there's there's no clear guidance around TB preventive treatment in that population. What are your thoughts on prioritizing that group for prevention? And then my second question is, if you were to prioritize TB preventive treatment in that group, would you do a test of infection or just start TBT?
Thank you. We'll take more questions and then the panelists would respond. Did you want to? Yes, please, at the other end.
Good afternoon, everybody. My name is Sami Adedokun. I work with MGIC. First, I want to congratulate all the presenters for doing a good job. My first question goes to, or my first 2 questions goes to the first presenter. I'm curious to know what the inclusion criteria were, especially for participant selection. Looking at the prevalences, I was wondering whether you were looking at people that were symptomatic. Secondly, I missed what your tests, your diagnostic test, but I was wondering whether it's able to detect atypical MTB. And then my last question goes to the last one present. You recommended further training for infection prevention and control. I'm sure a lot of those trainings probably for people who work in DOTS clinics, and I'm just wondering whether what we might consider doing would be to have some form of ensuring compliance with the IPC strategy that they have been previously trained on. Thank you.
Okay, thank you. I see 3 hands here, so we'll take 2 more, and then they would respond. So shall we go with Professor Rosemary, and then we haven't forgotten you, Ola.
Thank you very much. The presentations were quite brilliant. The first question I have is to advise. I'm not sure I heard you well. You said from your study amongst these health workers that you now have a cohort that's available for clinical trial. What you said, talking clinical trials among health workers. I want you to please expatiate on that. And then for the viral, febrile illness surveillance, the report you were presenting, I saw PCR testing and positivity rate. Is the positivity rate from the PCR or from the rapid tests that you will do? So you didn't distinguish whether it was a PCR report you were presenting or was a serology. Please do let us know. Thank you.
Thank you. And Dr. Nadia.
Thanks, everyone. It's so great to see. I'll just focus on 2 questions. One to KK. About BTG and boosted darunavir, right, as a treatment in the study. But do you have any idea about any trials comparing that plus that's carbohydrate and rilpivirine? And if or not, what are your ideas on how one will fare against the other? And then for Rita, lovely presentation. You are testing 9 different, look like 9 different infectious diseases that are causes of febrile, and you're doing it for surveillance. But I want to ask, what do you see is the R&D innovation here? Because I'm thinking, did you do this as a as a panel testing? That is, are there any panel tests? I'm thinking clinical surveillance, because part of the issue in diagnosing febrile illness is so multifactorial, so many diseases, that there are a lot of studies going on in other countries, other African countries. What are your one blood draw?
Thank you. Panelists.
Can you hear me? Okay.
Yeah.
So I'll start with the first question, which talked about how long we followed up these patients. So we followed up the patients up to 90, but we assessed the primary endpoint of the study. That's the critical, finding of the study at 48 weeks. So in terms of the efficacy of the treatment, because I think you asked, was there like a fall in the viral level as follow-up? Yes, we found a fall across the 3 arms. But what made the innovative regimen or the innovative arm special was that the rate of fall was markedly more than the standard of care, and as well more than the TLD. So considering the fact is fewer pills within fewer pills, health perspective. So the aim was to do something new other than what we already had. We had the 3-arm regimen, and this was looking at the 2-arm regimen and how efficacious can the 2-arm regimen be in given the same clinical efficacy. It was initially planned as a non-inferiority trial, comparing it to the standard of care, but at the end of the day, we've seen it's actually a superior regimen. So why do we need to add cabotegravir when you don't fix something that is not broken? So it seems like the whole idea is to have fewer pills that can give us the same clinical outcome, that can improve the quality of life. They had less anxiety, less depression, and all those things. So maybe that could be planned in the future, but as it stands now, this seems to favor most stakeholders.
Thank you. That's it. You can use that one. Don't worry, they'll bring the volume up once you start talking.
So let me start from inclusion criteria.
Is it on? It's not. It's not on. You can use this.
Okay. So this was the question from Dr. Sami about inclusion. 3 criteria. So we selected healthcare workers, but three main inclusion criteria we had for those enrolled in the study. I think you asked a question about diagnostic. So we use the gamma release assay test. We use the quantiferon plus test provided by QIAGEN for this work. I'm not aware if the test has any issues with NTBs, non-tubercle mycobacterium. I think it's very specific for action, but I am open to your view. In terms of cohort for clinical trial, what I meant is that we've been able to characterize, should you want to trial involving healthcare workers, we've been able to show, and our findings could be generalized within the context of North Central Africa, Nigeria, where we conducted in Abuja and Nasarawa State. So we've been able to characterize that and have baseline characteristics that will be necessary for sample size calculation, recruitment strategy, or other interventions that might need such information. However, within the same cohort, we can still contact them should they be interested in participating in a trial, such as the TB vaccine trial that involves them. Now going to Violet, I can remember your first question, the treatment for healthcare workers. I do know that based on the LTBI guidelines that was developed by the country, there was a meeting in Lagos, and the question was, should healthcare workers be included among, priority population for TB preventive treatment, other than on the fives or PHIVs or those who are contacts. And I think in that meeting, we suggested that it would be important that healthcare workers are in moderate risk population that should also be added to those who should be targeted for preventive therapy. Unfortunately, we didn't ask that question when we were conducting the study to see what was such preventive therapy. To do X-rays, because which is part of the guideline that once you are positive, you should do an X-ray. But accepting the X-ray wasn't, very few people came for X-rays, even though it was paid for. So we'll set in how much acceptability, except the duration of treatment is within a 1 month period or a short regimen for that. I think your second question was tested before treatment, if I get you right. Do we need to conduct IGRA testing before being placed on treatment? My personal thinking will be, considering the cost of IGRA testing, it will be, for it to be more strategic, there should be more targeted testing. Certain populations of certain healthcare workers should be given the priority of being tested, given the fact that the risk of infection, acquisition, and potentially progression may be higher among those healthcare workers. And in that way, we could better use the IGRA testing within our context.
Thank you so much. Over to you, Rita.
All right. So the first response to your question. So yes, I presented 2 results. The first 2 pathogens were pathogens tested through antigen-based rapid diagnostic test, malaria and SARS-CoV-2. The rest of the virus, the dengue, chikungunya, Lassa, and all of those were tested via PCR testing. Yeah, and to Dr. Nadia's question, so, I guess we can continue the conversation after. So it was a very long conversation to identify a cost-effective laboratory platform for all of this testing. What we're doing is a multiplex for chikungunya, dengue, and West Nile with Zika, and flu fever, and singleplex for mpox, right? We couldn't get a platform to have all of this together. And then also this was based on the capacity also available at the reference laboratory. Yeah, thank you.
And your point is well taken, Nadia, that if we really want to make this effective and get the results back so that it's used for management, we've got to find a better way of doing it. Right now, it's really based on doing PCR, and like she mentioned, a number of pathogens at the same time, but sometimes there's interference with the primer pairs as well. But certainly getting a diagnostic that will move it closer to management rather than surveillance. It's, considering how much febrile illness is a problem here. But I think that this surveillance would give us an idea of the suspects, right? Relations, depending on the season as well, because that's one thing we're trying to do right through the season. Was there a question for, yeah, go ahead, please.
Yes, well, I agree with you that IPC, healthcare workers have been trained in IPC, but our study we had some findings from our study. Number one, the laboratorians scored low on knowledge, attitude, and practice. And across the 3 cadres too, practice was an aspect that they scored low on. Now, 2 things come readily to mind. Number one, we all know that this is adult education. And in adult education, you need to train and continue to train, because an adult needs to unlearn whatever wrong practices and now relearn a new one. The second aspect also is the availability of resources and the conduciveness to be able to practice, to be able to have good practices. Unfortunately, our study did not ask why, but we just wanted to just evaluate the level of knowledge, attitude, and practices. I think this can be something that can be explored further. Thank you very much.
Thank you. And did you have any? No, you don't. So a follow-up question that I have for you, Dr. Edom, is that are you surprised by your finding? I certainly am. If we think about practices, especially protective ones, the laboratory, I mean, this is standard for them. So I'm surprised that the knowledge is that low and the practice is that low among the laboratories. Dealing with pathogens, it is a concern.
Yeah, and another thing that we even found was that the practice in private, because we had one private healthcare facility, was way better than in the public healthcare facility. Although for knowledge, on knowledge, the public healthcare facility healthcare workers scored higher on knowledge compared to the private. But when it came to practice, the private scored higher compared, and that was the place where we what came to mind was availability of resources, the environment. Then another thing again is we found that laboratories they don't come in contact with the patient, and some of the things that happens is that they tend to most of the messages that go around always targeted coming in contact with people. I think it's high time we start reframing these messages, and also take laboratorians into consideration. The need for public health enlightenment on how to better handle samples in
Yeah,
infectious
that
disease
makes a lot of sense. Thank you so much for that. They're very respectful of the age itself, but in terms of interacting with individuals, they haven't awareness. That really makes a lot of sense. Now, if you have questions, and then we'll go to the videos, because there were, I know Ola, you have a question, or you did.
Prof?
It's fine if they answered it, and I see an arm there, so we'll have just two questions then. Please go ahead, Ola.
Good afternoon, everyone. My question is to Dr. James. Looking at your study, right? You had 6 months post booster dose, and you have another about 6 months interval again. So don't you think your studies are at the risk of having high rate of lost follow-up, such that your patients, your participants already, they've had this booster dose and they've gone on a very long break, and you're asking them to come back. So what do you think?
Thank you. One question there.
Yeah, thank you. I think my question, I think the other one has been addressed by Dr. Edu. But the one I want to talk about is about the febrile index surveillance study. I would like to suggest that if we can take the study to do the genomic, because these days you realize that some of the pathogens, that some organisms that are actually non-pathogenic before, we've seen cases where you go ahead and do genetic genome sequencing, and you realize that that particular pathogen usually is non-infectious. Now it has become virulent and is causing disease. So this will give us a direction on where to go and which particular species of that particular pathogen is actually being virulent and is causing this disease. So I would like to suggest that the research team take a step further and do gene sequencing, if there's still resources for that. Thank you.
Thank you. Thanks very much. Were you answering the question? Okay. Please, James.
Yeah, thank you very much. Obviously, loss to follow-up is something we are worried about, and we're not going to sit down and wait for 6 months before making contact with the participants. So there's going to be ongoing contact with those participants to remind them of. So we will maintain contact with them. we're not just going to sit and wait. Otherwise, we may, as you said, lose some of those participants. Thank you.
I think it's fair that you address the genome sequencing question as well.
Well, I wasn't actually really listening, but obviously, the scope of what you want to do is limited by the funds available and the kind of questions that you've asked have been issued. So, yes, it's important to sequence because that's when you know what you're really dealing with. That suggestion is a good one, but we've got to think of the funds. Thank you.
Well, haven't they just done amazingly well? Can we just appreciate this panel? Thank you so much. Now the presentations are all on video and should be really brief and wouldn't take too much of your time. So thanks again for your patience and please enjoy.
Studying key findings. Good morning. My name is Sophia Osawe. I work for the Institute of Post on infected. First looked at the microbial structure, how the breast milk microbiome influences the infant gut microbiome for to pediatric vaccination. And was the HLA that influences the humoral responses. We were funded by NIH for 5 years, and we enrolled mother and infant parents in Jos, Nigeria, and Cape Town, South Africa, the total of 300 mother infant parents. Just to give you a snapshot of the methodology as well, we enrolled 200 HIV positive mothers and 100 HIV negative mothers and the infants. And we quantified the anti-TT titers, so that's IgG antibodies, using an ELISA methodology. And we tested the mothers at baseline while they were pregnant and tested the infants at 2 time points, birth and week 15. So week 15 is after the last DPT shot, which the infants get at 14 weeks. I will focus on data from the Nigerian cohort, and you can see by my left that the HIV positive mothers had lower titers than the HIV negative. However, this was not significant. But at birth, we measure the titers in the infant, which will mirror the placental transfer of these anti-TT antibodies. And as the protective titer was set at 0.1, as I mentioned earlier, we looked at the proportions of infants that had protective titers at birth versus protective titers at week 15. And we can see the HEU, which is in this orange line, had lower proportions of protective titers as compared to the HU infants. Looking closer at the titers between these two infants, the HEU, we can see here that we had lower titers compared to HEU infants, and this association this comparison was significant at 0.02 at birth, and it's also significant at week 15, with the HU still having lower titers compared to HU. This is significant difference, and at week 15 is where they have received the booster DPT shots. What are the implications of our findings? So we see that overall the differences between these two infants based on HIV exposure at both time points that we looked at. So the HU infants have weaker humoral responses to the tetanus vaccination that they receive. Our data highlights that HU infants have altered immune responses, and this will lead to a recommendation that should focus on new approaches that can improve these responses that we see in this group of infants. An example may be considering a booster shot for vaccine-preventable diseases, as this may be quite similar with other vaccines. Thank you so much for your attention. I would like to acknowledge the entire beaming team at IHVN and also at the University of Cape Town in South Africa, and also our sponsors. Thank you for your attention.
Hello, everyone. My name is Alima Jediaga, and today I'll be talking to you about the BRIDGE study. BRIDGE is the breast cancer early detection to reduce delays to diagnosis in Nigeria. So I'm the presenter of the BRIDGE study. Okay, so the full study title is actually the feasibility and acceptability of a mobile health intervention using community health care workers in order to reduce delays to diagnosis of breast cancer in Nigeria. The study objectives will develop a novel low-cost mHealth application called the BRIDGE app that will educate care workers to recognize the signs of breast cancer, perform clinical breast exam, and refer patients with symptoms. The second objective was to build local capacity by training community healthcare workers to act as patient navigators using the BRIDGE app in order to facilitate a faster referral process for women who presented with suspicious symptoms. And third was to implement a pilot study using the BRIDGE app to improve early detection and shorten diagnostic delays, and also to assess the feasibility and acceptability of its use in Nigeria. In terms of study design, it was an interventional pilot study, and study population was women 18 years and above presenting with breast symptoms. This study was funded by the Conquer Cancer Foundation of the American Society of Clinical Oncology. The total amount of funding was $20,000. Duration of the grant was 12 months plus a 6 months no-cost extension as a result of the COVID-19 pandemic. We carried out the study at 6 primary healthcare facilities, 3 intervention and 3 control sites in the Gwagwalada axis of Abuja. The number of participants enrolled was 64, and this study was done in collaboration with colleagues at the Department of Global Health Informatics at the Mount Sinai Hospital in New York and Duke University in North Carolina in the US. Okay, so breast cancer is the most common cancer among women in Nigeria and globally. And in low and middle income countries such as Nigeria, over 70% of women present late. And the main reason why women present late, where survival is poor and outcomes are poor from breast cancer treatment, is delay. So delay to diagnosis really is an issue. And if you look at this figure here, which is a summary we put together in one of our papers, you can see that delay ranges from about a month in a study that was done in Nigeria to about 16 months. So this is from when a woman first recognizes a symptom to when she has a diagnosis of breast cancer and when she eventually starts treatment. So very heterogeneous time across sub-Saharan African countries. But what is similar among all the countries is that it's greater than 3 months before a woman actually gets a diagnosis and starts treatment. Again, these graphs, the one on the you can see that for women who presented early, 1 and 2, for stage 1 and 2 breast cancer, there's over 90% survival in women compared to late stages. Well, the number of providers, women, this on the second graph here, we can see that for women who just had one provider, they presented earlier than women who visited 2 or 3 places. So again, that really tells us about patient navigation. So moving on to the bridge study. So we've established the fact that there are long delays to diagnosis in Nigeria, and that is what the bridge study was seeking to address. So to do this, first of all, we had to assess current knowledge levels of community healthcare workers and nurses about breast cancer and the current referral process. Next, we sought to develop an intervention to improve their knowledge and strengthen the referral system. And finally, to implement the pilot study to test the feasibility and acceptability of the intervention. We started off by creating awareness, doing community sensitization, reaching out to the communities, especially the intervention communities where we sought to deploy excuse me, the Bridge app in their primary healthcare centers. So that's the team there visiting some of those centers. Then moving on, we carried out a baseline survey to assess current knowledge of nurses and community healthcare workers on breast in general by any potential gaps in knowledge, which really now helps us when we moved on to the next step to develop operations and collaborators at Nai Hospital. After we developed the app, we now pre-tested the app for 2 weeks, and after that, we carried out key informant interviews of community healthcare workers to assess excuse me, to accessibility and feasibility of the app. And finally, we set the study. Baseline so we did in terms of age, it wasn't significantly different between the nurses and the community healthcare workers. But what we found, the different knowledge domains of breast cancer risk factors, signs and symptoms, clinical breast exam, the nurses did significantly better than the community healthcare workers, as we would expect in the base day. So after that survey, we went on to train community health workers from all the hospitals, both the intervention sites and the control sites, and then one nurse from the referral hospital. And then we tested their knowledge, the training, intermediate test immediately after the training, and then a post-test. And what we found was that knowledge across all the domains was increased. The highest level of knowledge gain was in the signs and symptoms, and the least was in clinical breast exam. But knowledge increased across all the different domains for the community healthcare workers. So in terms of the feasibility and acceptability of the Bridge app, what we found was that all the participants, that's the community healthcare workers, were satisfied with the app. They reported good user experience. They said there was an easy to follow logical question flow. It had good speed, and there was adequate technical support as well. So whenever they had any issues, they were able to contact the data manager on the Bridge study, who was able to sort out these issues. Also, the community healthcare workers made a video on how to do the clinical breast exam. The reminder function in the app as the most liked feature. So there was a bit there for them to really see how we can then practice. So up with the who they had prepared just to ensure that they get to the tertiary hospital. So after we found that the app was easy to use, questions or issues, chronological question flow, and all of that, my version, which we now use in the pilot study. The pilot study, we enrolled 64 women, and 69% of these women had completed primary or secondary education. About 60% had a personal income, so did not have to rely solely on their spouses or family for financial support. 80% of the women we saw presented with a breast lump as their first recognizable symptom. So again, this just points to the fact that here breast cancer is symptomatic, unlike in Western countries or in more developed countries where it is picked up by screening before a lump develops. So we also found that there are some challenges to the referral process, and there was some unwillingness to visit the tertiary center. And reasons were that, one, there was a lot of ignorance on the part of the women. There was a fear of surgery. There were lots of financial constraints. In Nigeria, cancer care for now is borne out of pocket. There's a cancer health fund, which the Federal Ministry of Health and the Nigerian government has started. But again, it will take time for this to be accessible to a lot of the women that need the cancer treatment. So we also found that women had to seek permission from their husbands to seek care. There was also a long distance from villages to the referral center, and there was a belief in traditional medicine, which was quite widespread, and the fact that this appeared to be a more accessible option for the women. So what did we find? Well, about 64 women presented at these hospitals over the 6-month period that we enrolled them. So of the 64 women, all 64 were referred to the tertiary hospital. However, only 42 of them turned up at the tertiary hospital. Of the 42 that turned up, 28 of these women were investigated, and 7 were confirmed to be cases of breast cancer. During the same time period, in the control hospitals, 24 women presented with breast symptoms at the control sites, and none of these women were subsequently seen at the referral hospital. In terms of the time and delay, women from the intervention sites who were referred to the referral hospital were seen by a breast surgeon within 6 weeks of referral. So the Bridge app was really useful in reducing that provider delay and ensuring that at least once women got to UATH, they were seen and investigations were carried out. In terms of the study limitations, one, we had some app synchronization issues. So sometimes the community healthcare workers would enter data into the app, and it would take a while for it to reflect for the data manager at IHVN to see what had been entered, or even for the nurse at the referral hospital to see that patients had been referred and were coming through. Another issue we had was poor network in some remote areas. And then there was also limited data export functionality. So these are just issues that we are planning to work on as we deploy the app in a larger study. So what are the implications of the Bridge study? One, I would say, is on breast cancer knowledge. We found that at baseline, nurses had more breast cancer knowledge than community healthcare workers. But what was interesting to note was that after training the community healthcare workers, they now went on to have higher knowledge than the nurses had at baseline. And this has implications for task sharing, especially in communities where there are very few doctors and nurses. it shows that community healthcare workers can be trained and used as patient navigators to ensure that women with breast symptoms are identified and sent to the referral hospitals where they can get prompt diagnosis and access to treatment. The second implication is on delays to diagnosis. The Bridge app we found was a useful tool for referring women. And in our study, we were able to reduce referral times to less than 3 months in these women. And of course, this has implications for stage of diagnosis and ultimately breast cancer outcomes in women who are diagnosed and eventually go on to have treatment. This app could also potentially be tested in a larger study to assess its impact on reducing delays to diagnosis and strengthening the referral system in low and middle income countries. In terms of dissemination of our research findings, we presented a presentation at the International Cancer Week in Abuja, Nigeria, and presentation at CUGH in 2021. It was a virtual during the COVID period. Currently, we are working on 2 manuscripts. We have the first drafts ready and now just getting ready to source manuscripts. Thank you very much for listening.
Hello, good morning, good afternoon, depending on where you're tuning in from. My name is Adam Abdullahi, and today I'd like to give you some insights into some of the work that we've been doing in terms of understanding population vaccination rollout. I have no conflict of interest per se, but a significant part of this work is funded by the Africa Research Program and the Gates Foundation via Pangea 2 in Nature Communications. So back into vaccine, one, the SARS-CoV-2 came to West Africa, studied exposure levels to SARS-CoV-2 before the vaccines came, and for this, we set up this really nice with the Nigerian Institute for Medical Research in Lagos, where 140 healthcare worker patients were recruited, and samples that were collected before they received the first vaccine, we tested very specifically, as on the right panel, the antibody that is generated against SARS-CoV-2 when you get exposed, which is the antibody to the core of the virus, which is called the But we also wanted to extend our understanding of exposure to SARS-CoV-2 before vaccination in a West African setting. And to do this, we're able to again tap into another cohort of general population, in this case, at the Kwame Nkrumah University of Science and Technology. And we found relatively the same trend. So a similar proportion of people were exposed to SARS-CoV-2 before the vaccine came. But because of the large numbers that we had in this particular cohort, we wanted to extend this analysis and do sensitivity analysis as to what particular test is best to help us tell people who are being exposed at that time. So for this, we set up special tests which detected the antibodies that your immune system makes against the core of the virus, which is the anti-N, but also to other parts, including the anti-RBD, which is a bit more specific now. On the panel on the left, anti-RBD is that S, that spike protein at the top. Anti-RBD is the actual part that binds to your cell. So we did all these array of tests. And we found in the end, with the key point really being that this particular antibody that is generated against the anti-N, which is the core of the virus, it's not good enough to tell you people who've been infected, and you need a combination of multiple tests. And also this paper has just been accepted as of last week into the American Journal for Tropical Medicine and Hygiene. So using this preliminary data that we've been able to generate, we wanted to now set up a really, really nice study that tells us a few things, including the impact of exposure levels to how HIV positive individuals respond to vaccination, but also in this very unique population in West Africa that poor vaccine access has allowed a lot of people to have been exposed to all the different variants of concern without getting a vaccine. So their bodies, in terms of the immune system, has already been imprinted with all of these different SARS-CoV-2, and then you vaccinate them with a Wuhan virus to see how they respond, which is the reason why we set up the scenario study. And the scenario really is this longitudinal prospective cohort study, where around 300 HIV positive slash negative controls have been recruited. And we really want to use this population now to study antibody responses, but also cellular responses in detail, including the impact of all the exposure that people would have had to SARS-CoV-2. And we're doing this, we started doing this around 6 months ago. And we want to do this over the next 3 years. And we have 2 study sites in Abuja. And we're collecting plasma samples, peripheral blood mononuclear cells, nasal swabs, and stool samples, because we also want to study viral evolution, but also the microbiota in these particular patients. So just very quickly to show you through this, the study schema, as I already explained, the patients would have, after a month, they collect the first time point, and then they get a booster, and then we collect samples a month later, and then at 6 months intervals subsequently. So the significant activity achieved so far, so we've been able to recruit a total of 332 patients from this particular cohort. For the rest of the time points, the recruitment is ongoing at the moment across the different time points, depending on how we recruited patients at the start. So we are at the moment finishing the completion of data collection from all our study participants that we've now completed recruiting. But also we collected questionnaire data at the study baseline, which is at the point of entry into the study. And we're just starting to now get some interim analysis that we're hoping will start making sense of going a bit into the future. So next steps and expectations, broken this down into 2 phases. So the first really in the HIV negative cohort, which we hope to finish recruiting by mid next month. We hope to start doing the interim analysis with that particular cohort up until 1 month after their booster doses to really evaluate the impact of immune imprinting. What does it mean to have been exposed to potential concerns in the past, and then get negated in terms of antibody responses, but also cellular responses, including doing in-depth characterizations of these particular responses, including single cell sequencing of the B cell receptors to really see overall impact of exposure and immunological imprinting. So for the second phase, which we'd hope would be by the end of this year, in terms of the analysis, we found that we want to potentially have a look at the impact of HIV as a virus and viremia in terms of the different viral loads that people would have and how that potentially impacted on the immune response. And the second part of phase 2, really, with the hypothesis that because of people were relatively perhaps protected by a certain level of immunity or exposure levels that would have already existed, no variant of really able to dominate within a West African setting. We really want to also, so potentially we could study whether if the virus changes in this particular setting, but it's not able to become a dominant sort of strain of the virus for factors we don't necessarily hope to understand. But also we want to look at the impact of MHCs and HLA types in overall responses in this particular cohort. So there are some other auxiliary projects that are ongoing at the moment, including in this particular cohort that we had dolutegravir mutations by characterizing, again, intra-host evolution in people who might be infected with SARS-CoV-2, and how co-infection with HIV may sort of allow the virus to change in certain ways. We're also at the moment setting up the dovetail study, which is a population level study. We assess overall clinical outcomes, but also resistance outcomes, HIV patients who've been treated with dolutegravir over the last 24 months. And finally, the Praline study is just really at its concept stage at the moment, but it's really potentially looking at what population level factors really impacted on the sort of responses that we saw at the start. Despite exposure levels, we didn't see severe outcomes when people got infected with SARS-CoV-2. We really would like to characterize what immunological factors, rural, urban factors that would have led to this. And we have some paper as well that will probably come out next month, accepted in the Journal of Antimicrobial Chemotherapy. So just to acknowledge everyone who's really been who's really been involved in all of this study, Professor Lashley, Dr. James, Dr. Martin from Cambridge, and then Professor Ravi, and then all the key personnel really as entire part of the scenario study and all the other studies as well. Special thanks to the management and the team at IHVN and Cambridge, and significant thanks to the funders, including the Cambridge Africa Program and the Gates Foundation via the Pangea too. My apologies again in advance for having to do this in absentia. If you really do have any questions, please, you can either direct them to Dr. James on a more sort of implementation basis, but if you have some personal questions as it relates to a lot of the work that we've put forth here, please, you can email me on aa2291@can.ac.uk, but also abdullahi at ihvnnigeria.org. We also do some science communication on Twitter at Adam Sizzler. Thank you so much for your time.
I'm sure if I tell you there's another presentation, you will all shout at me. But we need to bring this to a close, and to just say a very big thank you to all of you. Professor Salako, Eshego, it's not usual to have very busy chief executives of government agencies to stay this long, and we're very grateful. And of course, to our board members, it's payback time. All right, I remember I sat in this long also, let me board members that especially those that are non-health scientists, economic scientists are here, and they've stayed this long. To Papa, when I say Papa, you know who I'm talking to by now. Papa, Mama, and Pekin. Don't say anything after that. Really very, very grateful to you and to our chairs, especially my boss, Man, Steen, and the others that are here, and to those. The presenters were in two groups, slow speakers and the speed presenters. So those that were